Good afternoon, everyone, and welcome to the launch of the American Democracy and Health Security Initiative. I'm Beth Cameron, Senior Advisor and Professor of the Practice at the Brown University School of Public Health Pandemic Center, and along with my colleagues, Steve Morrison and Catherine Bliss here at CSIS, Gary Edson and John Bridgeland from the COVID Collaborative, we are delighted to introduce you today to this effort and to a group of people that we're calling Lamplighter's, who we're featuring today. Steve is going to do the opener in a few minutes, but I do want to quickly say that we launched this project with an impossible question, which is, can we actually bridge divides and overcome pandemic polarization in America? We talked to people across a number of states, looking mainly at Nebraska, Indiana, North Carolina, and Washington, but also many others. And I think the answer to the question that we asked is resoundingly yes. But let's hear from them first. Thanks.
COVID really led us to an important crossroads.
There are two truths to America's pandemic experience. We're a country that experienced failure and polarization. We're also a country in which leaders, and we're calling these leaders Lamplighters, stepped forward to guide us out of crisis.
The Health Security Initiative presents the story of the American COVID-19 experience. This effort has unearthed a plea to capture what worked, to build sustainable bridges for communities to do better next time.
American democracy and our health security are deeply connected. We cannot let divisiveness erase hard-fought learning.
Being a lamplighter would have some kind of impact on being able to carry some of the lessons into other areas and to bring it forward.
It's not a question of if we're going to have to go through this again. It's a question of when. We need to use this opportunity so that when the day comes, we can do better in our response.
A 9/11 style thing brings everybody together, but a pandemic forces you by its very nature to stay apart.
It's impossible to say, I've got this plan that we can bring all the American people in. They're all going to trust everything that we say in public health.
The enemy is not each other. The enemy is the virus itself.
How do we keep these kind of events to be Team America?
No one had playbook. And so we said, let's develop the playbook.
A lot of our successes, I really attribute to the leadership that we had at the time.
I had to be in charge. A governor has to lead the effort. The public needed to see one person who was leading this effort, who could communicate and bring everybody together.
Engage the business community because they cut through the politics and let them take a leadership role.
In a situation as incredibly important as this one, it becomes even more important to fess up to things that turned out not to be either true or effective.
COVID was not a medical problem. COVID was an organizational challenge.
We weren't dealing with a situation that emergency managers usually are managing resources. Right. We're now managing shortages.
One of the biggest lessons that we learned in COVID is that the ability for data to flow freely between the local, state, and national level is really vital for us to be able to respond to a national or global pandemic.
We didn't have the information technology or the infrastructure in place in order to track and collect data. And that was something that I did by talking with our hospitals until we were at the point where we could get that data and display it on our public dashboard.
The legislature increased public health funding on a go-forward basis that I don't think would have happened but for COVID.
Alaska remembers the 1918 pandemic. They often refer to it as the Great Death. And oftentimes I hear about this time as the Great Resilience and the ways that America had ingenuity, creativity, and we found ways to problem solve together.
Start the conversation by asking people to bring their practical solutions to things. Starbucks helped us with the people moving. We also had folks who were expert at marketing. Think about how do you market a vaccine campaign?
When we were trying to source PPE, a lot of states came together to try to figure out how do we do this better, faster together. The way we built that coalition was through something that would become the STAT network. Rockefeller was willing to make a major order, invest their resources up front, and then states were able to order off of that.
We paid our people for when they got COVID for whatever it took them to recover. We wanted them to get better. Many of the solutions that we would come to rely on were local because many of the challenges were very unique by their locality.
We worked on a mutual aid agreement between the tribes and the local health jurisdictions. So to have it go right for the first time ever was a really big deal.
We did something called Black and Vax to target that population. We did door-to-door campaigns.
The people who started Latin 19 were very intentional of putting community members first. And this was the first time that leadership was hearing about some of the issues that patients were facing in the community.
It became really clear that education and being out of school for children was going to be a problem.
We created the ABC Science Collaborative. We wanted to trust that people knew their local circumstances and situations better than we did, but we could provide the science and then they could apply it to where they needed to go.
The thing that was the greatest success was American ingenuity. We really have to be able to take the private sector, take the healthcare sector, take public health, and then trust people. Let's harness that. And that's our path to victory and success.
Hear, hear. Well, good afternoon and welcome to all here in person and all online. I'm J. Stephen Morrison, Senior Vice President here at CSIS, the Center for Strategic International Studies. We're delighted to host today the launch of the work of the American Democracy and Health Security Initiative entitled Lighting a Path Amid Pandemic Polarization. First, I just want to say a few words about how we got here, because the genesis story itself is quite compelling, I think. 18 months ago, in January of 2022, we gathered together here a group as an experiment here at CSIS. It's Catherine Bliss and myself, it's Jennifer Nuzzo and Beth Cameron from Brown University Pandemic Center, Gary Edson, John Bridgeland from the COVID Collaborative. And we asked ourselves, this was at a moment where we were a bit shaken and weary from this pandemic, and we sort of asked ourselves, what actually has America experienced, particularly outside of Washington, across the nation? We had seen this startling clash of democratic values, such as individual freedom, with the urgent quest to protect communities. We'd seen against biological threats. We had seen the erosion of trust and confidence in the toxic polarization and spread of falsehoods. And one of the questions we had was, is this inevitable? And is this the only story? And was it possible to surmount these forces? And we put out a quick call to many of you that are in the room here or tuning in today, to a wide array of state and local leaders, as well as former officials from the Bush, Obama, Trump, and Biden White Houses. And it was a test to put the question on the table, is this a propitious moment to begin to understand what happened to us and how this is to inform the future? And we deliberately mixed experts on democracy with health security experts, Republicans and Democrats, community organizers, mayors, corporate leaders, federal emergency authorities, and managers. And among us were several who had served and participated in the COVID policy group, the remarkable group that Philip Zelikow had pulled together for the previous 18 months. And the response we got to the test, to the call that we put out, was frankly pretty stunning. Yeah, people jumped at the chance to join this conversation and to come together. There was no amnesia that we experienced. It was quite the opposite. It was an awakening. It was a bolt of energy. It was a very clear will to share and unpack what we had experienced. And that's what gave birth to this project, was that test, that moment of test in January of 2022. So here we are, 18 months later, to share with you the work that has followed and that many of you have contributed to in very significant ways. Our three organizations bonded together and set out to engage with over 75 leaders from across the country, as we've heard from Beth, a number of different states. We wanted to know from them what worked and what did not work, how they evolved approaches to flashpoint issues, and more. What did we discover in that process? There are a couple of key things we discovered. First is two stories. The story of how America fared under the pandemic is actually two stories. The well-known one of national failure, loss, and polarization and trauma, and the far lesser-known story of state and local collaborations and innovations that bridge divides amid very adverse circumstances. both of these stories are true. We're not by any means in this project minimizing the first story of national loss, failure, and polarization. It's clear to all that we have yet to properly memorialize or honor the more than 1 million Americans who lost their lives. The darker story has been unpacked expertly in Lessons from the COVID War, produced by the COVID Crisis Group, led by Philip Zelikow. Many of us participated in that group. And that study highlighted one of the conclusions that we've heard in our work, which is that communities were forced to improvise when the federal response broke down. The question then becomes, well, what exactly did happen? And that's been our key purpose and focus. The second thing is 2 core values. American democracy and health security are both front and center in this particular enterprise. They're both inextricable. American health security depends on maximizing our ability to live in a free society and manage a public health emergency simultaneously. And likewise, the health of our democracy depends on citizens' faith in their institutions, our schools, our workplaces, and especially our government to protect them in a crisis. Somehow, we now struggle to find a way forward that both respects the individual freedoms that we hold dear and supports the collective good. And one of the hard lessons is that when we allow these 2 values to be seen as in opposition to one another, as in collision, we pay a high price for that, and we need to avoid it. The third concept I want to emphasize is one that Beth already flagged, which is the concept of lamplighters. We focused on the less understood positive story. We've systematically chronicled state and local innovations. We focused on a cross-section of states that reflected geographical, socioeconomic, ethnic, political diversity. And we interviewed those leaders, those lamplighters themselves. We sought them out, we found them, we won their trust, we got them to share with us what they knew. They bridged divides, they faced uncertainty with grit and humility. They listened to meet people where they were, and they struggled often successfully to turn blunt, binary, and divisive tools into more surgical and flexible instruments that respected personal freedoms while promoting the common good. You'll hear more of their stories today, and all of them can be accessed on our website. We've gleaned a number of stories and important findings and over 20 recommendations in the report. All are important and urgent, but what I want to do for just a few minutes is highlight 9 top-line points. And then I want to thank many of the people who contributed so much. The first point is the answer to the question of where does the buck stop in an emergency? Lamplighters recognize that it's not enough to merely follow the science. Lamplighters emphasized that not only is the science so fundamental, it's often imperfect, but it's fundamental, but it also must be weighed together by elected leaders with the social, educational, and economic impacts of the response. That's a complicated and delicate challenge that leaders face. And the conclusion that this leads you to is that public health officials and science must inform the fight, but the elected leaders, governors, mayors, tribal leaders, are the ones charged with leading that fight. The buck stops with them. The federal response, the federal support remains essential. We're not delving too much into that. We'll touch on the federal response in some of the discussions. But in our American system, the leaders at the level of governors, mayors, tribal leaders, community leaders, truly bear the bulk of operational responsibility in the midst of a biological crisis. Second point is competency. Lamplighters placed a premium on operational excellence to meet people's needs and on collaboration across stakeholders. General Stan McChrystal called this a team of teams. And the conclusion that this led us to is that governors were most successful, and other leaders were most successful, when they appointed a highly skilled emergency response coordinator, an incident commander with proven operational expertise and a 24/7 command structure that could break down and transcend silos and bring in the interests of health, business, education, and civil society leaders. Third point is flexible playbooks. You'll hear a lot about that. Policy failures left pandemic decision makers with this very limited set of tools, of blunt binary options that deepened our divisions, when our choices were simply to shut down or open up, or to protect health versus protect jobs. Lamplighters were the ones that improvised, that developed more surgical and flexible tools tailored to the community economic and educational needs. And where does that lead us? The conclusion that leads us to is that we really need to put a focus on developing these flexible playbooks. That's key. It's a priority, should be a priority to prepare those and fund those now, not later. They need to be adaptable, clearly, and accounting for worst case scenarios and addressing the special challenges faced by schools and businesses. Fourth point is inequity. We must prioritize vulnerable communities that will be hardest hit if we're going to ensure equity and limit impact, death, disease spread, and deaths. Lamplighters did this by leveraging networks such as Latin 19 North Carolina and the American Indian Health Commission in Washington State. And these networks proved to be vitally important in addressing food insecurity, bringing life-saving vaccines and other forms of support that were needed in disproportionate ways. Then the conclusion is that this leads us to is that pandemic leaders today really need to strike fairly advanced formal arrangements spanning state governments, tribes, community organizations that prioritize a vulnerable and underserved populations and strike that strategy for reaching them. The fifth point is around data. The absence of a one-stop shop for quality, actionable data left state and local pandemic leaders flying blind often without the situational awareness needed to target the response on vulnerable populations, avoid hospital collapse, safely reopen schools and businesses. And Lamplighter stepped into this vacuum and they created their own bespoke dashboards using information pulled from universities, private sector medical sources, non-governmental sources. And that conclusion, the conclusion that leads us to is that we really need to concentrate on improving data looking forward. Getting it in place is difficult, it's controversial, and it demands high political will. State and local leaders, we're arguing, should press ahead on modernizing their data capabilities to inform their emergency decision-making. They should be demanding higher federal support in that area. At the same time, the U.S. Centers for Disease Control and Prevention should fulfill its mission as a one-stop shop for data dashboard, situation reports, technical assessments, support to those state and local leaders. That too is controversial and difficult, but there is no choice. We have to proceed on both fronts. Sixth point is around procurement. Stymied by scarce supplies and by a federal government that was an unreliable shipping clerk, state and local leaders competed with one another in a pandemic Hunger Games for protective gear, for testing and other essential supplies. Some of the Lamplighters bonded together to establish independent procurement pathways, such as STAT, the State and Territorial Public Health Network, that focused on testing and other commodities, supported by the Rockefeller Commission. Even today, there's no single dedicated channel, official channel, on that interface between state and federal demands and needs. And the conclusion we're pushing for is that the White House Office of Pandemic Preparedness and Response should designate a national supply coordinator to play that role of being a reliable interface with states. And the STAT network, we should take special steps to sustain the STAT network into the future. Seventh point is around training. The COVID pandemic revealed the need for more systematic training for the next generation of pandemic decision makers. Many public health officials are not formally trained in crisis response. That shouldn't be a surprise. They speak a different language from national security professionals and disaster response officials. We shouldn't be surprised at that either. Training for future pandemic decision makers should include planning for worst case scenarios, and we need a national training center focused on health emergency decision making and communications. Sorting out how to create that is a challenge. We don't have a definitive answer to that, but we're tabling that as a priority. Eighth point is about where do we turn? During the pandemic, decision makers and the public were bombarded with disparate recommendations. They were from a confusing and often conflicting array of sources. Legitimate debate was oftentimes muted. Misinformation, disinformation flourished. Lamplighters struggled amidst that to know where to turn for quality, quick, and reliable advice and wisdom. Our conclusion is that we should push for a standing bipartisan experts group, a prestigious national council charged with providing recommendations and situation reports on health security, comprised of leaders drawn from health, education, and the economy, reflecting the full diversity of America. We're not likely to see a national commission investigating COVID, the pandemic experience, as we've seen after 9/11 and in other moments, but we can foresee, it is within our reach, we believe, to create a standing national council that could acquire gravitas and legitimacy and be there in the next crisis. The last point is about trust, which cuts across all of the prior points, and in fact should have probably been the first point, but it's the best point, I think, for concluding here. All Lamplighters highlighted trust as the most precious commodity in a crisis and emphasized that the pandemic gravely eroded trust in government, science, experts, institutions, and in each other. Cuts across all sectors. And the conclusion that we've drawn from that is that trust is not bestowed, it's earned. And it's earned every day through performance. It's earned by prioritizing the vulnerable, by ensuring operational excellence, by collaborating across silos, by showing humility and admitting mistakes, and by respecting open debate, listening intently, communicating very clearly and competently, and balancing respect for personal freedom with promotion of the global good. Before we turn to our first panel and hear from our Lamplighters, I want to just offer special thanks to a number of people. We've heard from Beth, Jen Nuzzo, Catherine Bliss, Gary Edson, John Bridgeland. They're the core team that pulled this all together. We have 33 Lamplighters. We have over 75 sources of folks who gave us their time. We're grateful to all of them. At Brown University, Lisa DiCarlo, Akel Patterson, Britt Lampert, Carly Gasca, Nellie Bristol, Marla Ramash, Amanda Kogan, Bentley Holt, Michael Mitchell, and the Dean Ashish Shah. That's a lot of people. Brown University brought a lot of people to the table to make this all happen. Vinca LaFleur is with us here from West Wing Writers, a dear friend and colleague over several decades who came and brought her remarkable skills to this. Judy Monroe is with us today, CDC Foundation, who's been with us in support from day one. The National Academy for State Health Policy, NASHP, played a vitally important role in guiding us into this search. And that included Hemi Tawarson, the executive director, and Katie Green and Maddie Haraber, some of whom are with us today. From CSIS, many colleagues worked very hard. No one worked harder than Sophia Hirschfield. Alex Kisling, Michaela Simoneau joined in. Our streaming and broadcasting team, Dinesh Makani, Kiju, and Arturo Munoz, all very grateful to them for pulling this all together. So thank you all for your patience. Thank you for being with us today in person and online. And we'll now move to our first panel. Thank you.
You're such a wonderfully cooperative audience, and we're so thrilled to have you here. I just say, the country does so little to tap the ingenuity, creativity, and entrepreneurial spirit of the nation. And when we do, extraordinary things happen. I see so many heroes in this audience today. Judy, thank you, the CDC Foundation, Georges, all you're doing, the Public Health Association, Stephen, with our COVID collaborative, Senator Burr, on and on and on. All this talent. So the theory of action of this project was actually to reach out across the United States and tap the talent and insights of these, what we call Lamplighters. So on behalf of the COVID collaborative, which was an outgrowth of when pandemic meets a system of federalism, you need an all-country response to try at some level to tap that ingenuity. I first want to thank some extraordinary partners and leaders. You heard about the capacity of Brown University's Pandemic Center, but I want to thank Beth Cameron, who's literally been sending emails at 3 and 4 o'clock in the morning to all of us, Jennifer Nuzzo and their team at Brown, Ashish, and extraordinary work you all do. Steve Morris and Catherine Bliss, their team at the Center for Strategic and International Studies and its Bipartisan Alliance on Global Health Security. You see why this place is like thriving with people all the time because of the high quality work they do. And I want to give a special thanks to someone who's not here today, my co-leader at the COVID Collaborative, Gary Edson, who helped co-found the President's Emergency Plan for AIDS Relief, was the visionary behind the Millennium Challenge Corporation, has just worked night and day on this project over 18 months. During the pandemic, the COVID Collaborative worked most prominently with governors. And one of the best things we did was reach out to the then vice chair and then soon to be chair of the National Governors Association, someone I think is one of the people of the highest character and integrity in this nation, whose voice is needed now more than ever, Asa Hutchinson. We're privileged to have two former governors who each held leadership positions in the NGA on our panel today. Governor Asa Hutchinson was the two-term and very popular governor of Arkansas, vice chair and then chair of the National Governors Association, including during the pandemic. President Reagan appointed him. He was the youngest United States attorney in the United States. He was administrator of the Drug Enforcement Administration and undersecretary at Homeland Security. I've known Governor Hutchinson since he served in the Congress, and it was a privilege for me and Gary when we were in the White House to serve with him in the Bush administration, particularly after 9/11, another great moment of crisis for the nation. Christine Gregoire is the CEO of Challenge Seattle, a former two-term governor of Washington State, also a former chair of the National Governors Association. She served as Attorney General for the state remarkably for 12 years. During the pandemic, she played a major role in setting up the command center and bringing the business community in the middle of the response. The panel entitled What We Learned will be moderated by our great partner, once again, Steve Morrison, who you know is a great leader here at CSIS. So Steve, Governor, and Governor Gregoire.
Hello, Governor Gregoire.
Hi.
There you are. Great to have you with us today. Thank you so much for joining us.
You bet. Mutual.
So we have 30 minutes for this conversation. The theme of this session is what have we learned? I'm going to start by asking you each a broad question, which is drawing from your leadership career. What are your reflections on what's most crucially important for effective leadership during health emergencies? What is it that in your mind, as such a thing broke, you understood and continued to learn was most critical for effective leadership? Governor Gregoire, you want to start off?
Sure, and thank you for what you and all of the people you've mentioned have done. This is exactly what we need so that we're ready to go when this happens again, unfortunately. So when I got the news on a Friday night that we in our state were the first to have a death, I brought together all of our major company CEOs that are members of my organization, Amazon, Microsoft, Starbucks, Boeing, and so on, and said, you're global, you know what's going on around the world. We need to provide some very much needed leadership, but be a real partner to the governor of the state of Washington, whereas you just said the buck stops. So we began the process there and really quickly learned when we started a weekly meeting at noon, sometimes twice a week, of the CEOs, which grew from my 21 CEOs to about 200 across the state, where we brought in experts and we brought in data and we brought in folks who were experts at state government, and we realized leadership here is not just with the state. They can lead and do many things that the private and philanthropic sectors can't. But there are lots of things that the private sector can do and must do in this kind of crisis that cannot be done by government, and the same is true of the philanthropic sector. So what we saw here in the state of Washington was leadership across the board, but in a very collaborative way in support of the governor and what he was undertaking to do. Leadership by philanthropy, leadership by business leaders, but all working together, seeing this as an absolute humanitarian crisis. Politics had no place. We wanted data, facts, and information. And what we did is we tried to communicate that in a way that we would say what we know now, having brought experts to our weekly meetings virtually across. Within 2 days of that death, 2 major companies, Amazon and Microsoft, decided to work from home, and the rest of the business community followed. That's the kind of leadership I'm talking about. Our governor stood up and did what I consider to be an amazing job, but he recognized he needed partners. And that's why I think, in the end, could we have done better? Absolutely. But we really did do what was necessary for us to be able to save lives. And I mean lives of those who are most vulnerable as well as everybody else in ways that we had never, ever done before.
Thank you, Governor. Governor Hutchinson, your thoughts?
It was great to be with you, and extraordinary initiative that's very important for our country. So thank everybody who's participated in this. I've always said that we needed a 9/11 type review, and as a governor of Arkansas during the pandemic, I wanted someone to second guess decisions. I wanted a national review. What was done right, what was done wrong. I think you all have the right tone. I do believe it's going to really get some resonance as leaders prepare for the future, and I hope it does. And just paint the picture, in Arkansas, our first case was March 11 of 2020. So by that time, we observed what had happened in Washington. They got hit first, and the challenges they faced in dealing with it. We had seen Italy, we had seen across the globe the challenges, and we didn't know what we were dealing with. You remember in March of 2020, we were told they weren't even sure how it was carried, and that you had to, clean everything whenever you bought something in the store. I mean, so it was just so much that was unknown. And so we were prepared, though, because we saw what had happened. We declared an emergency. We set up our incident command center. I was fortunate to have a Secretary of Health that was an infectious disease doctor that had spent time in Africa, who CDC, by the way, later recruited. And as governor, we went through 3 directors of health during the pandemic. So it was tough on everyone. But you had to be able to make decisions. Just to paint the picture, we had our state basketball championship going on, all the championship games, and no one wanted to make a decision as to whether the game should continue or not. And you had the NBA cancel their season, and you had the Southeast Conference cancel their tournament, and we've got our high school players. Who makes the call that they should go home or keep playing? And, it wound up being in my lap. We made the call. I said, finish the game and then go home. But looking back on that, that was, I'm a basketball fan, so that was hard for me to do. I'll just put it that way. But that was the environment. And so I think the lessons learned that are positive is you have to have a centralized coordination of your leadership team. And the coordination is an important part of it because the private sector, as the governor pointed out, is a critical part of it. We had the medical community involved, but it was also our economic recovery efforts. And so all of that was part of the centralized effort. And one thing is for sure, while the legislature has given the governor emergency authority, you've got to make sure that all branches of government are coordinated in terms of the response, particularly legislative branch and the executive branch. But it has to be that coordination. The second thing, of course, is the communication. And we started on day 1 when we declared an emergency with a news conference with a briefing. We did it on day 2, on day 3, day 4, and after we did that for 14 days in a row, I said, boy, we got to quit this. And someone said, no, you can't. People are depending upon it now. And so we continued that communication for close to 100 days in a row. We had over 200 press briefings during the course of the pandemic, each of those that I led. And that is one of the lasting impacts, was the day-to-day communication. And it wasn't, it was having the health community and the science there to convey to the public as to everything that we knew. And I said, you're on this journey with us. What we know, what we face, you're a part of it. When we make a wrong decision, you're going to know about it. And so even to this day, people come up to me and say that meant a lot to them, that day-to-day communication. And the third part of it that I think you nailed is the balance. That we have the science, but we have to deal with the culture in our communities as to how do people make a livelihood? How do they support their family? The schools, and how are they handled? We learn so much through it. And one key point that you make well, and that needs to be hammered home, is it's a balance between the science and the practicalities of living and what it means to our social health, our educational health, our culture. All of those are factors in the decision making. And that's why governors, I think, play a really key role, obviously, in dealing with that balance.
Governor, can you say a few words about your leadership role in the National Governors Association? Because you were in that role right in the middle of the pandemic. How important was that, and to what advantage and to what achievement? Say a bit about that.
Well, first, the National Governor Association is the last standing effective bipartisan organization in America. It actually works and functions and brings people together. I'm very proud of what they did, particularly during the pandemic. And what it did was you had 50 governors and territorial governors on the phone listening to ideas as to how to face the pandemic and the innovation that each of the states are trying to carry out. We had the White House Coronavirus Task Force through both administrations weekly talking to us what our needs are, what the challenges are. And of course, one of the big areas was, first of all, it was the testing. Secondly, it was the PPE that was needed. And I never thought when I ran for governor that I would be on the phone to a factory in China begging for factory time to produce PPE for our state. And then they tell us, I'm sorry, I know you reserved this time, but New York just outbid you. And so that's what I had to do. I was calling CEOs of testing companies and saying, can we purchase? We've got money, we'll put it on the table. Can we purchase your testing equipment? And they say, well, the federal government under the Defense Production Act has told us what we're going to produce and where it's going to go, so we're having to listen to them and not you. And so those are the challenges that we face. And yes, your recommendation is right on target. You know, the procurement is something the federal government can assist the states in and support us and help us through that. And that was one of the biggest challenges. The National Governor Association, those calls, we were able to tell the president or vice president of the United States or the coronavirus director, we need testing equipment. We're out of it. We need different types of equipment, and they would be able to be responsive to us within the constraints that they had. So the NGA was very instrumental.
We interviewed Governor Hogan for another project looking at CDC, and he was recounting when he was in a leadership position in the NGA, the tempo and cadence of meetings, and it was extraordinary, the number of calls.
It brought us all together. I mean, we don't ordinarily have that level of communication between the governors. Democrats, Republicans, all participating in it, thoughtful questions, listening, and it was just really reflective of the benefit of understanding the differences among the states, how we can solve problems together, how we can say that doesn't work here, or we can embrace it and say we want to steal that idea.
Governor Gregoire, I'd like to hear any thoughts you have on what we've just covered, but I'd also like you to add some insight into the nature of the corporate sector in Washington State. When we had the interview with you, we went into in some detail around the civic mindedness and the fact that the leadership was ready and willing to lean forward and partner in ways that had not been done before. And I'd like you to explain that. Why was that possible? I mean, there was leadership to tap it, but there was something else happening there.
Well, you're exactly right. And what happened, it's a very memorable telephone call that was had between several of the CEO along with the governor, in which the governor said, "What can you do to help?" And the head of Starbucks said, "You know, we deliver about 2 million cups of coffee to satisfy customers globally every week. We can take any mass vaccination site that you're standing up and we'll make it customer friendly and we'll make it more efficient." The head of Microsoft proceeded to say, "What you have by way of technology is not up to what is necessary here. We can send a team in, we can get you ready, you're going to be able to make that happen." We had Costco CEO stand up and say, "We've got contacts globally for PPE and we're willing to go out there and make purchases for you and bring it back so that you have what you need." That was a Friday afternoon. We recommended a command center so that we'd be one central spot. The governor went out and announced on that Monday, "I've created a command center. It is a public-private partnership. We're going to take on technology. We're going to take on communications. We're going to take on how we can be efficient, effective in mass vaccinations." The results of which, for example, there wasn't one mass vaccination site in the state of Washington with the Starbucks team that didn't improve by at least 30%. When Microsoft came in and said, "You're going to need a vaccine locator, an instrument for the public," and stood that thing up right away. And Costco, to the governor's point, where we were fighting each other in this country for PPE, Costco was there for us in making purchases globally. Alaska Airlines was flying the PPE in, and the list goes on and on. But these CEOs, when we initially approached government, found that there was a little concern about, "You guys really doing this because you want to contribute, or are you asking for something?" And we made it clear it was a humanitarian crisis that could only be addressed in partnership. We had to take the best of what the business community could offer in partnership with the best of what the public sector had to offer and the best of what the philanthropic sector had to offer, because they have trusting relationships with many of the population that we needed to reach, and they were capable of making that happen, where government and the business community could not. So we all came together. We identified some problems. For example, I remember one very distinctly where we said to the governor, "You've got your hospitals independent in silos, basically fighting each other. That'll never, ever succeed. We can't do that. We need to come together." So we recommended to him that he get that central person, Admiral Bono, whom I know you're going to hear from later, and she did a masterful job of bringing our healthcare system together, particularly our hospitals, so we weren't fighting each other, but we were uniting to defeat the enemy, which was COVID. So I look back now with absolute respect and admiration to everybody who stood up and said, "It is a public-private partnership that is the only means by which we get through this thing. And we must be able to communicate to the public, hear them out, respect them, be open, be honest, be transparent, provide them with what information we true or we think to be true, and ask them to do what they felt was the right thing to do, and communicated by all of the companies in the state that joined those weekly calls, over 200, to make sure that information was out. So it was an amazing public-private partnership, and I wish we could make it happen every single day on every issue that we deal with.
I get the impression that governors spend a lot of time on the phone. Governor Hutchinson, how does what Governor Gregoire say square with your experience with the private sector interests within Arkansas?
Well, very much so. Now, you know, we don't have Boeing and Starbucks, but we do have Walmart. We have Tyson's Foods, and we got JB Hunt Trucking. So we have a different set of private sector resources. But you think about whether it's distributing vaccines or whether it is testing or other PPE, who does a better job of distribution than Walmart in the communities? And so that kind of expertise is important, and that's why the flexibility that a federal government has to give the states is critical to be able to get it out equitably and efficiently as well. And so, yes, it mirrors that. You know, we had a challenge, though. We have in Arkansas a very large Marshallese population. And they worked in the poultry plants, which was essential, obviously, to produce protein during the pandemic. And we had to have special resources applied to assist that population. And so every state's unique, and we have to approach it in unique ways.
Say a bit more about how you coped with the flashpoint issues, which we've sort of bundled together as mandates on testing, business closures, schools reopening, closing and reopening. As you reflect in your role, in your leadership role, what did you learn and what was most effective in managing those flashpoint issues?
Well, I mean, first of all, everybody probably wants a few do-overs on those flashpoints, but you know, the first one that came very early was the schools. Yeah. And whenever you look at, no parent wanted to send their child to school in March of 2020 during the middle of the pandemic. In the early stages of it, we knew very little. And we went remote, just like everyone else across the country. But then I made the decision that this is not going to work. And it was a decision that I made based upon parents and students and everyone that needed not just the education, but the social interaction that a school provides and the protection of it. And so we said, we're going back to school this fall. And then the cases went up nationally, and we had teachers very concerned about it. I stuck with it. So that was a flashpoint. And it was simply a matter of listening to our communities as to what was needed and what was working. And we said we needed to have in-classroom instruction. And whenever I stuck with that, Arkansas actually ranks number 2 in the nation for days of in-classroom instruction during the pandemic. And so that was a flashpoint that I think we managed well. When it came to the mandates, Arkansas's resistance of it, there's a reason that we have bootleggers and marijuana growers in our history in the hills of Arkansas. We don't have a fondness for government telling us what to do. And so there was a lot of resistance, but my health director, I said, we're not going to shelter in place. National pressure to shelter in place and define one business as essential and another business as non-essential, and the non-essentials has to close down. I said, that doesn't make sense to me. We analyzed it, we studied that. I said, no, we're not going to do that. And even though the White House was saying, don't do anything, let's shelter in place through April, and we didn't do it. We kept our businesses flowing. I think that was the right decision. But part of that was my health director said, okay, if you're going to keep your businesses open, here's what's going to protect everybody. At least do the best we can, which was a mask. And so we encouraged that. I set the example. I put it on. I went out in a news conference with a mask on. And then we put in place a mandate for a time, and then we lifted it. But it was all designed to keep things flowing. But those are flashpoints and the resistance there. The other flashpoint that came up was we wanted to have a statewide standard where everybody had the same rules to follow. Everybody was roaring in the same direction. And as the cases went up, and you had, some cities that looked a little bit differently at these issues than I did. And so there was some pressure to go to break that partnership apart from the cities versus the states. And ultimately, as the pandemic progressed, we gave more flexibilities to our cities and our schools to manage these issues, but for some time, we tried to make sure that we were all going the same way with state direction. So that was another flashpoint that we had to manage through.
And Governor Gregoire, tell us a little bit about how the state of Washington coped with flashpoint issues, but also the division of the state itself. It's really two quite different entities between the East and the West, two different capabilities, different political culture, different economic realities. How did the state deal with that?
So one of the things we tried to do, very consistent with what the governor is talking about, is anticipate what was going to happen as best we could, with the benefit of these companies being global and having seen what they had already seen, whether it was China or India or France, wherever it was. And so, for example, we did 3 economic reports to the legislature and our delegation, which were used by our delegation on the floor of Congress to get help out to the states. We asked that the schools be reopened, and we gave clear data and information about how we felt that could be done safely and the negative consequences of having our children virtually learning rather than being at school. We did a best practices how to return to work in a safe and secure way. We did a best practice on how to open the schools, including higher education. And we presented all this by the end of that first year to the legislature and the governor. And they took the information, the data, the statistics, the best practices that we've been able to accumulate globally, and began the process of, okay, how do we deal with these issues that we're having? You're exactly right. We are a state that has, rural, a very different political mindset versus very urban and the mindset that's there. We made a commitment in partnership with the state that we were going to do everything we could to be totally transparent and give the facts as we were told they were. We are very fortunate to have 2 of the leading entities in our state from a healthcare issue with the vaccine and so on. So we were getting lots of important intelligence that we could convey. And then we asked all of them to convey that information out. And we worked with the philanthropic community to make sure they got it out to their respective communities that they were working with. The churches, the same. Businesses, small businesses in rural areas, the same. So we kept trying to make sure that we were being absolutely respectful, but giving people all the information, objective information that we were able to gather and respect the decisions they had to make, but get people in the community with whom they had trust that would listen to them as they delivered those messages. I think that in the leadership of the state was really helpful. Were we totally successful? Absolutely not. But like the governor said, it really did take us a long way in using that prior trusting relationship to deliver objective information and to be totally transparent.
Thank you. In the time that remains, we've got another 5 minutes or so. Governor Gregoire, I'm going to ask you first, and then we're going to come back to Governor Hutchinson. Thinking ahead into the future, what gives you the greatest hope that we're going to be better prepared for the next biological danger that we face? And what worries you the most about?
Well, number one, what gives me hope is you and what you all are doing. My greatest concern when we started getting through COVID was, the governor and I would tell you there's an after-action report of every natural disaster that you might experience. And we kept saying, where's the after-action report on lessons learned and getting more prepared for the next round, which will be inevitable. And so what you folks are doing is exactly what I think has to be done and what gives me hope. The other thing is, I really do believe here, and like what the governor said in Arkansas, the fact that everybody rose to the occasion. It wasn't anything but a humanitarian crisis here, not a political issue, a humanitarian crisis that brought people together that said, we have to help each other to get through this. Now, what am I concerned about? That, we have a way of confronting a crisis and then putting it behind us and moving on without taking the best of what we learned and redo what needs to be redone. The healthcare system in America remains suffering dramatically. The healthcare system we saw sat in silos and thus was really challenged. Healthcare workers and what was happening to them. The economics of those who were less fortunate during that period. So those lessons, I hope, will rise to the top and that we will take corrective measures so that we are better prepared, but that we always remember the only way we get through a crisis is if we all work together and we all respect each other and we all trust each other to do the right thing in the end.
Thank you. Governor Hutchinson, what gives you the greatest hope and what worries you the most?
Well, first I want to follow up with what the governor said, that there's a lot of challenges during the pandemic, but there was a lot that inspired us. And whenever I saw healthcare workers and I met with physicians and emergency responders and our pharmacist community, inspiring how they stepped up to the plate to meet the needs of people during the pandemic. One of the challenges, of course, is the division that we saw. And how do you deal with that division? And I think someone made the point earlier that whenever you're looking at a pandemic that obviously isolates people individually and breaks up communities, that's the heart of division. And so what holds us together in our communities? It's our churches, it is our schools, it is our families, and it's our livelihood. Those four things, and yet every one of those was hit hard. We exempted churches from all regulations, but they still were impacted, and some states had more mandates on them, did not exempt them. Whenever you look at the schools, obviously we've talked about that, and we've learned that, pulling schools apart or going remotely hurts us in our community, and that creates division in and of itself. Whenever we said that families cannot be present with their loved ones if they're dying in a nursing home, that took families apart. And we have to learn from all of these as to how we can minimize that division. And of course, the livelihood, people have to be able to produce and make a living and provide for their families. And we can't have the federal government paying for it all, even though they were very, very beneficial. So we've got to reduce all of those levels of division. And there's always going to be some, but I think that's important. National leadership is critical in communication. I think that failed us in parts during the pandemic as well. I've got to end on this because I think it goes at the heart of what your recommendations are, the one that I really care about, which is the balance. When I was, after 9/11 at Homeland Security, Senator Byrd's out there in Congress gave an incredible job description for me as Undersecretary for Border Security and to protect our country from a terrorist attack. He said, your responsibility is to protect our country from a terrorist attack, but to do so in a way that's consistent with the protection of civil liberties and the lawful flow of commerce. Isn't that an amazing statement of balance? And to me, the mandate for the future in health security is let's listen to the science, let's listen to the data, but let's balance it all with our freedoms, our liberties, and what holds us together as a democracy.
Thank you so much. Governor Gregoire, I want to allow you to leave us with the last thought on this panel here. today?
Well, again, I want to thank you, and I want to recognize all those who are taking this issue on now and leaving us with a legacy that we can remember, learn from, and improve. But I really fundamentally want to say thank you to all those who stood up during this crisis and did their best to make sure that lives were saved and protected, civil liberties were treated with respect, and we kept this country going in a way that at the local level was all about human beings willing to stand up and do beyond what anybody thought possible. So I'm proud of the country at the local level. I was frustrated at the federal level, but at the local level, there was amazing leadership that I think we all should recognize and be hopeful for, because that is what we are as a democracy. Turn us a bad coin, and we will turn it back and make it better.
Thank you. With these two amazing speakers, this is the easiest panel I've ever moderated. Please join me in thanking them.
In Seattle, we were kind of the epicenter. We had both the first diagnosed case at the time and the first diagnosed outbreak. And when we saw things developing in Wuhan, we were all flying blind because we could not tell how the disease was spreading, who was getting it. And so we ended up with the most blunt tool of all to stop the disease, which was to pull people apart. We got our first 100 to 200,000 test kits from South Korea because I couldn't get them from my own country. We've got to solve that for the future. You can't have this kind of scarcity model and Hunger Games. We have to think about how do we really anticipate what we're going to need, be honest about what we have and don't have, and use Operation Warp Speed for everything, you know? If we need more testing, let's figure out how to get more testing quickly. I was very fortunate. I was able to convene a group of experts who had international and national experience. And what I said to them was, don't tell me what to do today, what's coming tomorrow and what's coming the next day, so we can see around corners and really be thinking about how do we keep that trust that the senator talks about of the public, because once you lose it, it's gone. Mm-hmm. And they want you to be able to be square with them, to tell them the truth, to tell them why you're doing what you're doing. But more importantly, I think, is what can they do? How do they take power themselves? It's not a one-size-fits-all. What works in Seattle won't work in Anchorage or won't work in parts of North Carolina, let alone Texas, Florida. You know, the federal bureaucracy that has to do, for some reasons, cookie-cutter approach. When you're in a crisis, cookie-cutter doesn't work. They may need a snickerdoodle, I need chocolate chip. If you tell me the thing that we never utilized as much as we could, and the thing that was the greatest success was American ingenuity. And I think that's what we have to be able to trust and unleash. If you give the right people the problem set, they'll come up with some ideas. Some of them won't work. But, you know, that's where the whole laboratory of the states, I think it's the laboratory of the cities, that's my bias. We really have to be able to take the private sector, take the healthcare sector, take public health, and then trust people. Nobody wanted to get this virus. Nobody wanted anyone they know to die from the virus. Let's harness that, and that's our path to victory and success. Everyone wants to say what we got wrong and what's wrong with America. I think we got a lot right. We have to really focus on what worked. And I think every time we do that as a community, a state, or a country, we get better. And every time we focus on what we got wrong, we hold ourselves back.
We're just waiting for people to get mic'd. Feel free to talk amongst yourselves for a second. It looks like we're just bringing the next panel up. Apologies for the abrupt silence. And I'm going to turn it over to my colleague and friend, John Bridgelands from COVID Collaborative, who's got our next panel. Thanks so much, Bridge.
Thank you, Beth. So we okay? Everybody still with us? So welcome to our panel on commanding in crisis. The two extraordinary governors who we just heard from need their voices more than ever across politics to get things done. Talked about the importance of incident command and bringing in people who could help lead in a time of crisis. I'm going to ask a couple of questions, but we're going to open up to the audience and would love, get your questions ready. So Admiral Raquel Bono was director of the Washington State COVID-19 Pandemic Health Response. She's a senior fellow at Johns Hopkins University Applied Physics Laboratory, a retired vice admiral of the U.S. Navy, a trauma surgeon, and a former director of the U.S. Defense Health Agency. Thank you for being with us.
Thank you.
Gordon Larson served as policy director for Utah Governor Gary Herbert during the pandemic and is now the senior advisor for federal affairs for Utah Governor and National Governors Association Chair Spencer Cox. And Dr. Jeffrey Gold is chancellor of the University of Nebraska Medical Center and the incoming president of the University of Nebraska System. Congratulations, Dr. Gold. Could you give them a warm welcome? So as we've heard, multi-sector coordination, collaboration is both critical and complicated. You each sparked innovations in commanding these, helping to command these responses. And Admiral, given Washington State was the first state to actually have COVID cases, and Governor Gregoire singing your praises in terms of the governor of Washington tapping you to help lead the command. Could you share your insights? What were the elements of the secret sauce that made that response more effective?
Yeah, I appreciated the comments from Governor Gregoire, and I think he also heard some snippets from Mayor Durkin, also from Washington State. And actually, it was really easy being able to pivot off of the conditions that they had set. You know, in the military, we talk about prepping the battlefield to be successful. And we had leadership in Washington State with Governor Gregoire, the Governor Inslee and Mayor Durkin, and a lot of the community leaders who helped set the conditions for success. And being able to pivot off of them in so many different ways, I think really helped create that multi-sector, cross-industry conversation, and then more importantly, that collective impact, that action that we could all take.
Tell us a little bit more about what were those conditions that they set that helped make your work in 39 counties around the state of Washington more effective.
Right, and I know that I'd been asked earlier, I did not come from Washington State, so I was learning about the 39 counties while we were doing this. But Governor Gregoire talked about how she had the business leaders in a weekly meeting, and I spoke at that weekly meeting on more than one occasion. And while I appreciate the props she gave me for the medical conversations I had, working with Governor Inslee and the entire government of Washington State, I was allowed to go across many of the sectors, talking to the tribal nations, not only to the medical and hospital organizations, but I was talking to academic areas. I was talking to small businesses, and just being able to go across the state and get a flavor for what were those unique areas that were pain points to them. And the conditions that they helped set there were the expectations that we were going to talk to each other. We were going to go ahead and lay this out and have those conversations. So I think that having that state level leadership was pivotal and critical to being able to have those types of conversations.
Good. And I want to come back to you on hospital capacity, because you did extraordinary things, which we highlight on the website and in our reports. But Gordon, you talk about the importance of telling the truth, and share with us the command structure in Utah, what worked well, what didn't work well, and your insights.
Yeah. Well, I think a lot of what Admiral's saying rings true for us, as did the comments of both governors earlier. We were really fortunate to have Governor Hutchinson running the National Governors Association during that time, somebody who was clear-headed and thoughtful and asked good questions. So what we did in Utah is we initially started out, this was early March of 2020, with I think we called it the COVID Community Task Force, and it had leaders from the faith community, from business community, from the hospital systems, from education, both higher education and elementary and secondary. And it just brought to bear an enormous amount of perspectives. Now that eventually morphed into something else that I'll talk about in a moment, but to develop those relationships very quickly, it turned out that that was enormously useful, just knowing who to ask to get a particular answer. Within a few weeks, we decided we needed to have a unified command, and I think Governor Hutchinson spoke about this. Maybe it was Stephen that spoke about this, but the importance of having somebody who didn't necessarily have public health experience, but who knew what an incident command, what a unified incident command structure looked like. And so that turned out to be the Commissioner of Public Safety. So again, no medical experience, but he understood how to make information flow the right direction, both vertically and across sectors and within state government. And I think having people talk. Now, one of the interesting innovations that came out of that was a series of text chains. Now, of course, this wouldn't have happened even just a few years ago, but everybody felt you wanted to free up people to share ideas quickly and share information quickly. And even email has just become not as effective, but a series of text chains. There was a text chain on our testing team. There was a text chain that had that was focused on medical transfer. There was a text chain that was focused on business stuff. So being able to empower people to share good ideas, and sometimes the ideas were not good ideas, but you knew that you could share something without being shot down and at least throwing information up and down the chain, and that was really quite useful.
Dr. Gould, thank you for being here, by the way. We know you're going back to a board meeting. You have 3 different reservations on 3 different airlines to make sure you make that board meeting.
At the moment, I'm over 3. So.
Because of the weather, so you get special kudos. But you have talked compellingly about the critical resources in Nebraska that were brought to bear in government decision-making. And also, I was struck by the extraordinary work you did in rural areas. Could you tell us about both?
Sure. Well, first of all, I have a very severe case of imposter syndrome sitting here, so just so you know that. Secondly, I'm a recovering pediatric heart surgeon, so I have really little or no subject content expertise, as do most of you in this room have much greater. But very shortly after I came to Nebraska, I had the opportunity to...
Record, I think. Go ahead.
Is it not working?
No, I think you're fine. I think it's Gordon.
Oh, sorry, Gordon. I was hoping it was me. We were really called to action, having had a, quote, global center for health security built around the early anthrax and SARS days, a physical biocontainment unit and a well-trained team. And we were asked to repatriate American citizens from Western Africa with Ebola virus disease. And that was a real call to action for us to stand up, to build a trusted set of public-private partnerships, to work very closely with the state government, to work very closely with the communities, and also, frankly, to take a lot of risk to do that. That was not a series of low-risk decisions from not just a medical legal perspective, but from a community respect, trust perspective as well. But I think it built a lot of trust. And thereafter, NETEC was formed, the National Emerging Special Pathogens Training and Education Center. See, I got that right. I studied a little bit. And that created this network of 10 regional centers that were, dedicated to this. And so as the pandemic was evolving in the very, very early days, we were rapidly called into action. And so we were asked to repatriate just under 75 or 80 individuals from Wuhan City, again, American citizens. And then our team got an all-expense-paid trip to Yokohama, Japan, to repatriate the American citizens off the Diamond Princess who were sick into our quarantine and isolation unit. Some of them ended up in the biocontainment unit. I'm pleased to tell you, although it was an older population, every one of them went home alive and well, so I'm very proud of that. But that then catapulted into, thank you.
By the way, that's worth a little clap.
But that then, catapulted us into a very trusted position, both on the state level and on the national level. And, Nebraska is a relatively small state. Everybody knows everybody. And, the governor, members of the legislature, the local public health districts, et cetera, developed this very, very tight network. And to this day, every Tuesday morning at 9 o'clock, the coalition of the local public health districts, the which are 21 in number. There are 6 hospital coalitions geographically across the state that share data, that they look at challenges and opportunities, and that network was extremely important. So we had the infrastructure of pulling together the rural networks. But I think what the other piece you were alluding to is for the last 7 years, it's actually 7 years this week, we have had the opportunity to host a national television broadcast with the rural media group called Rural Health Matters, RHM, on RFD TV, which has developed a multi-million viewer audience. And its focus has been originally focused on healthcare in rural America, farming and ranching, industry, accidents, and sun exposure, and, you know, fill in the blank. You're talking to a kid who grew up in the inner city of New York, so I'm a little out of my, my range here. But that was a medium by which we could begin to listen to rural America and also directly communicate with rural America and bring subject content experts and recognize the fact that the science was the best we had at any given time. It was dynamically changing, and we were very open about the fact that we couldn't see the future clearly, but we had to make decisions on what we knew on a day-to-day basis. And it just developed an incredible following across the country to what it really is today. And, you know, just for relevance, Monday night, the subject of the show was high-path avian flu, and what that means to the producers in this country, and what it potentially means to the future of the, you know, what may be the next big public health crisis we face. Who knows?
Yeah, wonderful. Thank you. So COVID strained hospital systems, and you did very innovative things in Washington to strengthen hospital capacity. Could you share with the group what you did?
Well, you know, I could tell you everything, but with my military background, you might not be able to leave the room after that. I do want to just kind of piggyback off what something Jeff said, because I was one of your early participants.
Right. Yeah, through TED, right?
Right, yes.
So my former boss was Walter Ted Carter, was the president of the university system, and he introduced me to Rocky, and it's just been a great relationship. He unfortunately is now in a small institution in Columbus, Ohio, which is the circumstance by which I am ascending into his position. I learned a lot from Ted, but one of the best things I learned, Rocky, is he used to love to say that hope is not a plan.
That's right. Hope is not a plan, and that actually is how we kind of addressed the hospital system in Washington State. And I didn't, you know, as I mentioned earlier, I didn't have an appreciation for exactly how the healthcare system worked in Washington State, but they had very large private healthcare systems. They also had public healthcare systems, and they had academic healthcare systems. And everybody was under pressure. And it was really trying to find out what were some of the triggers for where their pressure points were and you know, where some of their where they were most easily disrupted in their systems. The piece that actually kind of started gelling us was having some kind of dashboard that we could all look at. And so being able to get all of the hospitals across the 39 counties to participate in providing data on this dashboard was, I mean, I cannot take full credit for that. I mean, we had people all in the counties. We had people in the health department. We had people in the you know, UW Medical Center and Washington State. Across the country, across the state, I mean, in all those counties, people agreed that we were going to share data. We had a very active and robust conversation about what kind of data would we want to share. And it typically had to do with PPE, the number of ICU beds, ventilators, and the staff. And being able to share that, we were able to actually make that available. There were, I'm really truncating how long this actually took, but we were able to look at this across the state of Washington and recognize when somebody was getting ready to go into overload or divert. And the overriding usage for that dashboard is that we would not let any one hospital go into crisis standards of operation or crisis standards of care. We would do everything as a collective and see ourselves as a health enterprise across the state. Wow. And drive that in. And it took a couple of unique forcing functions to kind of help people see that there was greater benefit in seeing ourselves as part of a larger enterprise. So it was fascinating to watch how all that happened.
Extraordinary. Gordon, you want to build on that?
Is this, can you hear me? Is that better? Maybe? I'll just talk loudly. How's that? No, it's interesting to hear you say that, Rocky, because we did the same thing in terms of the dashboard, which was really unifying for everybody to see the same data very quickly. But the other interesting thing is that when you talk, Governor Hutchinson talked about sort of the calls that we would do on a weekly basis with the White House and federal agencies, but the most useful part of that was the states sharing information with each other.
Yeah.
Oftentimes the feds were actually several weeks behind in terms of the data they were providing for decisions that we'd already had to make. But what was interesting is I think we learned from you all and we learned from Oregon, who kind of unified their healthcare systems as well. So we pulled together our 4 major hospital systems and said, hey, could we do something similar like this? They always wanted to make sure that they had a governor's office staffer on the call so they weren't violating antitrust laws, but they worked, I mean, to their eternal credit, they set aside profit motives largely so that they could work together. And the same thing as you said, it was sort of this patient's coming, which hospital system makes the most sense given everybody's capacity based on staffing and the other factors. So it was wonderful to learn from other states in real time.
Yeah, I know if Deval Patrick, who is still our co-chair of COVID Collaborative, were here. And by the way, tomorrow he and Asa Hutchinson have a wonderful op-ed that's getting published by STAT, so please read it. And Deval would say, I love this effort, lifting up the local and state innovations, but in a national emergency, you actually need a really effective national response. And so from the vantage point of states and preparing for the future, what would you hope your federal government would do differently and better in terms of the next health emergency? Gordon, should we start with you since you were working with the NGA?
I have no shortage of things there. I'll say one big thing and then a couple really quick small things. So I think we have to decide as a country what we want CDC to be. And I think everybody expected going into COVID, based on the name, that they were going to be the operational arm of the federal government's response. And they just were not prepared to be that. And it could go, I think it started with the testing debacle, but that had all sorts of secondary and tertiary impacts. But we need somebody we need some federal entity, whether it's CDC or not, that has the mission of providing their best real-time data. Now that's not going to, CDC's become sort of the retrospective, let's be the last answer on this scientific question, which was not what we needed during the pandemic. We needed the best real-time, which is that's a combination of science and conjecture, but that's what we needed, and we just were not getting it from CDC. So we got to figure out if that's what we want them to do and fund them appropriately. I think there, Scott Gottlieb had an enormous amount of really good counsel in his book, and one of them was that CDC should sort of set ahead of time, set right now the standards that they want, the agreements with the commercial and the academic labs, so that when we do have something come, they're already prepared to say, this is the deal, and we need you to ramp up your testing, and here's how we're going to do it. And it took a long time to do that. And the other final piece that I'll say is an idea that I thought was really innovative is the idea of paying, as a government, paying certain industries to build an excess capacity. So that might be pharmaceutical companies, it could be swab manufacturers, it could be the labs, those who manufacture PPE. They run on a kind of, just in time, let's just maximize our capacity, but we need them to have some excess slack, some capacity, so that when we do have an emergency of that nature, we can pay them now to ramp up production of a vaccine or whatever other commodities we need.
Those are great. Dr. Holder, Admiral, anything you want to add before we open it up for questions?
Well, one or two things. One is I think there was a perception going into this by the private sector, the large hospital systems, the states for that matter, that the federal government agencies and departments writ large, whatever that might be, civilian, military, etc., had adequate capacity from workforce, supply chain, knowledge, experience, communications infrastructure, etc., to deal with something of this proportion. And then there was the same, having spent a lot of time in the Pentagon and on Capitol Hill and in the White House during this entire process, there was a perception that the private sector had a resiliency and capacity and supplies and workforce to deal with a tragedy of this nature. And they were both wrong. And that's where we sit today, and it's closing that gap. Yeah. That's absolutely critical. The second point I want to make, there are three, I'll be brief, I promise, is that having spent a lot of time in the Pentagon with the Joint Staff, this was much more than a discussion about the health security of the United States. This was a discussion about the national security of our country, what was going on with NATO, and much more than that. And this was not just about ideologic political differences. This was truly about how to protect the cloth, those that wear the cloth of our nation, who protect our freedom. And indeed, that rapidly transitioned into a discussion of not just preparation, but prevention, response, resilience, and deterrence. And I would not underscore, living and working in Nebraska in the shadow of United States Strategic Command, that deterrence is the name of the game, particularly in the not just in the nuclear sector, but in the chem-bio sector. And then finally, I would say, if I would have had the biggest challenge that we face is really rebuilding trust of the American people, rural and urban, not just in the political agencies and departments, but in the communication systems. There's just so much divisiveness right now. And again, I'm not talking politically and ideologically. I'm just talking about people are questioning who to trust about health information, down to the question of should they get their kiddo vaccinated before they go to preschool. I mean, when you have families that are educated families that are literally asking that question and not knowing what to do, we have a lot of challenge to rebuild that trust.
Admiral?
So I had the interesting transition because I did come kind of from the federal government. I just retired from the military when I got the call to the invitation to come to Washington State. And so I'd gone into the state kind of with that federal mentality about how, at this level, we know what we're doing, and I was going to go in and help the state figure out what they needed to do, and to find out how much they already knew what to do. But here was the other lesson that I learned in that, is that a federal government and state governments, we're not that different. If you actually look at how people are organized and how they make decisions, and some of those constructs that I'd grown up with in the military and at the federal and the national level were something that I quickly recognized again at the state level. So I would say that, both sides have to realize that, to Jeff's point, they don't know everything, and there's still a lot to be learned from each other. But there are certain things, though, at the federal level that I think that I saw that did work well, and Operation Warp Speed, I would have to give chops, to that being something that we were able to execute on a fairly rapid fashion. And so I would suggest that when we're looking for those levers to help us move through a crisis, then we have to recognize where the accelerators are and where we can help build some of the public-private partnerships. And Governor Gregoire talked about doing that at the state level, but I think there's also a role at the federal level to really kind of amplify that public-private partnering. And then I'll just reflect a little bit more on what Jeff said. This was, from a military person's perspective and coming from the world's largest Navy, this was a much bigger condition than we were actually paying attention to. And so that, for me, was what really drove my thoughts and my focus when I was working at the state level, because it had to somehow roll up to what we were trying to do at the national level.
Excellent. Let's open it up for questions. Oh, come on, guys. He must have. It'll be like law school. We'll call on people. Yes. And state your name, affiliation, and your question, please.
I'm Chinwe Ochu, Doctor of Public Health degree student at the George Washington University and from Nigeria CDC. Thank you so much for very brilliant discussions. I'm just wondering, part of the things that came out of the program was that not having a national public health system in the United States played a key role during the pandemic, because pandemics go beyond the health sector. So we have different sectors working in silos, and there's no national coordination of the various sectors. So there's this idea that it might be useful to have a national public health system with a Secretary General that provides coordination across sectors and across disciplines. Do you think there's really a utility in that? And if so, is there a role you see the state actors playing in making that happen?
Wonderful question. Admiral, since you did this well at the state level, what are the prospects of that kind of coordination and integration at the national level?
Yeah. So I think it is a great question, and this is what I came away with after, and I think we're still dealing with COVID in some way, and I'm not entirely convinced that we have hardwired some of the lessons we learned, which is why I'm so very grateful to the work that we did here in the group with CSIS and the COVID Collaborative and Brown University. The pandemic revealed a lot of our frailties and our brittleness across the state and across the country. And what it also taught me was this is not a single sector, nor is this only a public health issue. It has to cut across the swath of that. And so putting a national public health is, I think that the intent to be able to have kind of a single level of data or ground truth or some kind of help with policy, I think that concept has merit. However, I think that it's more than a national health service that we're talking about. I think we're talking about a national collective to make sure that we're reaching out across this. This is never going to be a single sector issue, and it's never going to be a single sector solution. And so somehow we have to have some kind of forum that allows us to bring all that in. And I'm afraid that if we say that there's a national public health service, we'll end up constraining our thinking and our solution set. Not that I think the goals don't have merit, but I don't know if that will constrain us or actually help us amplify and broaden what our responses actually need to be.
Very good. Gordon, you want to add to it?
Yeah, just real quick.
Please.
I agree, and I think I thought a lot, particularly early in the pandemic, about whether federalism, our unique federalism, is a disadvantage in a pandemic. And my conclusion is it's not, especially given the kind of unique political culture of the United States. I'll just share one quick example. One of the advantages that we had in Utah, there was a study in early 2022 that looked back across the outcomes across the states on education, mortality, and economics. And Utah came out on front. Now, some people said we had a very young population, which is true, but they had accounted for that. They'd adjusted for that. But one of the things that I think we had to our advantage was really strong institutions. And this gets to sort of the democracy questions, but I think it also touches on this question, which is, I don't think a federal approach, a purely federal approach, could have understood exactly how do you reach these populations in this community. State and local leaders could, because they had a relationship there. And so I think for data, if you're just talking data, and Gottlieb has talked about this as well, the idea of like a kind of a national weather service, but for genetic sequencing and for other pandemic-related data, and I think that's a great idea. But in terms of like a policy or mandates, I really think state and local has much more credibility. Getting to some of Jeff's points about the loss of trust, and I think that federalism, that dispersed, decentralized power was important.
Very good. Other questions? Please. Georges. Come on, Georges. Dr. Benjamin.
Yeah, one comment and one question. The answer is we don't have a national coordinated health system to fit into that national response system, which we need to fix. So we still need to do that. And I think once we did that, and we actually do have someone in charge, it's called the Secretary of Health. We just never empowered it or functioned in that mechanism. I can tell you as a former state health official, we function quite well. And of course, in Washington State, you have a very organized public health system, which is why you were so successful to do that. But I'm going to take on the incident command issue because we do quite well with natural disasters. Now, granted, they tend to be relatively narrow, but the one we just had several years ago that went up the East Coast, and obviously Katrina and Rita were devastating from a regional perspective. We actually do quite well. We understand very much the incident command structure. We function well, but every time we have a health emergency, we reinvent the wheel in terms of that organizational structure. And you're right, we haven't really defined all the roles very well. Now, theoretically, now that we have a pandemic preparedness office, which probably is a misnomer. It's really a biosecurity preparedness office. But that aside, how do you see us putting in place a system which allows us to steer and not roll, so that we have the flexibility under our federalist system, but yet the national coordination that's necessary to do all the things we heard the two governors talk about, et cetera?
Great question. That's great. Dr. Volk?
Sure. Well, Dr. Benjamin, if you're asking me us that question, maybe we're in really big trouble. But,
I have the answer.
I'm sure you do. It's good to see you, by the way.
That's great.
I think a lot of this has to do with bringing the public and the private sector together. That I don't think either can do this alone. Yep. And I think there's tremendous power to have policy, data collection, standards, if you will, on a federal level. But I also see tremendous power on the local level as well, particularly as we talked about in confidence and trust building on the local community level. You know, one of the things that I was quite amazed at is we looked at the data very carefully, literally on a day-by-day basis, county by county. There are 93 counties in the state of Nebraska. That there was quite a bit of difference. And by having accurate real-time data, we could make decisions about staffing, hospital capacity, supplies, equipment, vaccine, antivirals, all of that, and make real-time logistical decisions, which, if you think about the ability to do that, I mean, maybe generative AI is going to change that in the future. Hard to know right now how that's going to play, but the ability to make those local decisions, I think, is very important. But I would not underestimate the willingness and as you heard from our governors and from our colleagues here, of the private healthcare systems, particularly some of the large academic medical centers. As I have a lot to do with the AAMC, just up the street here. And my colleagues in the Council of Teaching Hospitals really rose to the occasion, created not just clinical capacity, but did a lot of work in sequencing that was needed to be done when there was not a lot of capacity, had a lot of workforce. And so I think that's, another way that we can be better prepared. And then I'd also just add that one of the things I've been so impressed with the leadership teams in our institution is they rehearse the future. That is to say, pandemic preparedness, activation of biocontainment, quarantine systems, et cetera. It's one thing to have policy written down on a piece of paper in 8-point font that somebody stores in a dust-filled cabinet. It's another thing to periodically get out there, not just do tabletops, but to actually rehearse what are you going to do when the first transport comes in? How are you going to handle the staffing situations? How are you going to monitor the health of the staffing? And we learned a lot of that from the Ebola crisis, and so it was possible to just continue to rehearse. And I think the more we do that, not to create a state of alarm, but frankly to create a sense of confidence in the public that our systems, public and private, are rehearsed and ready to roll.
Can I say one other thing?
Sure.
And as life would have it, we have an opportunity to do that right now with the H5N1.
Yeah.
Amen.
Other questions, Dr. Phillips?
And we're not doing it.
Thanks, Dr. B.
Yes, hi, Stephen Phillips from COVID Collaborative, and wonderful panel and great moderation. Really enjoyed the comments. I'd like to drill down on data and data management, which Steve Morrison highlighted as one of his 8 key takeaways from the commission. It seems like we have a federalist system that is gimme. We know we're not going to change the federalist system, and which has both advantages and disadvantages in terms of managing a worldwide pandemic as a country with 50 states and 7 territories. As an epidemiologist, our lack of data systems that talk to each other across cities, states, is a real issue, and not only in in pandemic preparedness, as in disease reporting, but all across logistics, pharmaceutical distribution. When I say data that speaks to a pandemic, it's across a whole bunch of different systems and metrics. And other countries seemed, if you look at the globe, they faced the same threat, 185 countries, and many of them did a much better job of just data aggregation. And all that implies in terms of understanding where the pandemic was in terms of severity and responding to it in terms of getting PPE, testing, vaccines out to the people. So the question, a realistic question that I'd like to ask the panel is, if you just drill down on data management and what's possible in our federalist system, how would you go about next steps in figuring out what data needs to be collected and then what authority or mandate is realistic politically in terms of political will to get that done?
Great question. Admiral, you want to start?
Sure, I can take that one on. I think that is such a great question, and I think that you know, in data has always been very important to me, and it was extremely important for all of us during this time. But I also realized too that I was kind of handcuffing myself if I was waiting for the perfect data, or if I was trying to get to this kind of data that was, you know, collected, stored and washed, or washed and stored in the same way across. And I realized that some of the decision making that I was helping to, or set conditions for making, I didn't have to have the perfect data, but I did need to have reliable trends that I could follow. And that had even more meaning to me when I moved out of the state of Washington and was helping a private company restart during the pandemic in the midst of the Omicron variant. It was being able to have access to the data that was impactful to the group I was working with at the time, and not trying to wait for, you know, the perfect data that would guide me to the perfect decision necessarily. So I was just kind of looking for trends to kind of inform which way I needed to lean. At a much higher level and rolling it up at the national level, I think that is something that I would like to see, you know, some rigor and some help at that level, because that is where some of the that aggregation of data to become more actionable knowledge is really important. So I tended to look at it then as even though I wasn't getting the most perfect data, I was getting the kind of data that I could make some kind of decisions. And I know that in CSIS we've had a number of conversations about data and where it should reside and who should help manage that. But I think that in the practical sense, I realized that I had to go with what I had at the time, and then watch to see from that what the trends were telling me.
Thanks, Admiral. I've just been signaled that we're at time, which I always hate because there are other questions. But Gordon, you wanted to add on?
I'll be real quick. Two thoughts. One, I don't have a great answer, but the mandates is not the way to do it.
Yeah.
And that was highly frustrating when HHS would come and want us to bug our hospital systems to give them data. We're like, they have enough to do, don't bug them. But the other thought is, I think you have to, it has to go both ways. And it was aggravating for us when we were trying to do in our vaccination campaign, and DOD was unwilling to share with us the vaccination levels of people, Utah residents who worked for the National Guard or were civilian employees of DOD who'd been vaccinated. Same thing with the VA. And so it's got to be a willingness to share data both ways for the benefit of both the state and the federal government.
I loved how the last panel ended, which was what gives you hope. We don't have a congressional review of the pandemic. We don't have a national task force. There have been some books, some recommendations. It's sort of consistent with federalism, trying to learn the lessons from the ground up. But what gives you hope in terms of what you just experienced over the last 3 years in terms of the future, Dr. Gold?
Well, there's no question in my mind that, you know, having been a dyed-in-the-wool educator my entire career with colleges in medicine and nursing and pharmacy and dentistry, et cetera, that while we can look at the lessons learned by our larger communities, the health profession of the future the future, that are, who are going to take care of us and take care of our kids. Having had this experience and that awareness, I think sets the stage for being able to continue these discussions for at least the next generation to come, with a very strong willingness to build infrastructure, communication systems, workforce around this area. And that really gives me a lot of hope for the future. And hopefully, a lot of trust that our federal departments and agencies will coalesce around some of this, because I would tell you, my humble opinion, the single biggest tragedy potential of this entire pandemic loss, the millions and millions of lives around the world, would be to not learn the lessons from this and not turn that into sustainable operational actions.
That was so well said. We're going to end with that, also in the interest of your catching your plane.
Thank you.
And please thank the Admiral Gordon and Dr. Gold for this point. Thank you. Thank you so much.
We had to make a decision about the time others did to suspend school, but rather immediately, I wanted to raise the question, when can we get back and what would it take to get back? I put the question to them, is there a combination of actions we could take that would make it responsible to open in the fall? And if so, what are those? And they knew that a negative answer was entirely permissible. In fact, I guess maybe I expected it, I'm not sure. But they said that even based on the fragmentary information anybody had at the beginning, yes, they thought it might be possible, given an all-out effort to responsibly and safely open. Even in April, May of 20, there was plenty of reason to believe that a population like ours, average population of our community, and broadly defined, so students, grad students, faculty, staff, nearby neighbors, we calculated it under 35 years old. We entered with a mindset that it was our duty to stay in operation if we responsibly could. At the very outset, I said to our folks, I'm interested, of course, in the total numbers, total cases. I said, what I really want to know, in addition to how many cases, where they are, but I said, what I really want to know is severity. So I said to our medical advisors, can you not concoct a simple index for us? And they did, six levels. 1, asymptomatic. 2, 1 symptom. 3, 2 symptoms. 6 was candidate for hospitalization, very serious. And that's what I watched more closely than anything else. If that moved against us, that we weren't going to endanger anyone's life as a consequence of the decisions we made. That's the central lesson for the next time. And the next time will be something very different. The next time, for all I know, could be like 1918. Maybe you have to protect the young people more than others. I don't know. But when that happens, I hope that cohort of leaders looks back and says, as excruciating as this can be, and as uncertain as we're going to be, we got to try to protect multiple interests here.
Hi, everyone. One thing we neglected is to do introductions for our video. So that was former Indiana Governor Mitch Daniels and former Purdue President Mitch Daniels. It's in the program, but just to be clear. I have the great pleasure of introducing the next panel. Please join me on stage. We have Secretary of Health and Human Services from North Carolina, Cody Kinsley, former Chief Medical Officer from Nebraska, Ann Zink, and joining us by video, I think momentarily, the former COVID lead and former assistant administrator for FEMA. There you are, Dave. Coming to you live from Chile, I think, today, not from around the corner from my house, David Bebo. Please welcome the panel. It's great to see you all. Before I start the panel, one thing I want to emphasize about these three individuals is that while they all have a tremendous amount of obviously gravitas, professional credibility, and personal experience with public health crises, they are also all operators. And if you read their bios, you'll see a lot of usage of the word emergency and operational management. And so we're going to talk a little bit on this panel about some similar themes to what you've heard, but really we're going to drill down a little bit on operational leadership, that state and federal relationship. And so just to set the stage a little bit. So the theme of this session, I should say I'm Beth Cameron. I'm the Senior Advisor at the Brown Pandemic Center. I think I introduced myself at the very beginning, but for folks joining us now. The theme of this session is navigating chaos. And we purposefully talked about that because with each of you as we were doing interviews over the last year, because we wanted to speak a little bit about how unclear it was at the state level, some of the critical supply issues that we all faced. You all talked a lot about supplies, and obviously Dave's job in both administrations, I would add, was figuring out how to get shortages of supplies. As you heard in our video, you heard him say that we were dealing with scarcities. And you all dealt with a lack of data about those supplies and also about where those supplies needed to go. You also dealt with a lot of other things. So I'm going to start by introducing each of you in order. And I'm going to start with Anne. And what I'd love to hear from you at the beginning is a little bit about your COVID story, but with an eye towards in Alaska, in North Carolina, and at FEMA, the Federal Emergency Response Management Agency, which helped run our COVID response. What did you see that you feel like we could really build on for the future and replicate, but also, what went wrong with an eye towards operational management? And I'd love to start with you, but I'm going to go ahead and do an introduction to you. You really probably need no introduction to this crowd, but Anne Zink is the former Chief Medical Officer of the state of Alaska. She's also the former president of AASHTO, which is the Association of State and Territorial Health Officials, so has a much broader purview looking across all of the states during the period of time that we've been dealing with the pandemic. She's also, importantly, a practicing emergency medicine physician. So while she's in a public health role, she's also a crisis manager by training. And during her tenure, she guided Alaska through the COVID-19 pandemic and achieved some of the lowest case fatality rates in the country with very high testing. And I'm sure she'll talk a little bit about the testing challenges that they faced early in the pandemic. Anne, welcome. Thanks for joining us.
Great.
Over to you.
Thanks so much, Beth, for having us. And it's so great to see new faces and familiar faces and be on the stage with Cody again in this space. I came into this role as the Chief Medical Officer for the state of Alaska, perfectly timed about 6 months prior to a worldwide pandemic, and learned a lot in that process and in that space and time. And it was really fantastic to hear the governor speak. It brought back a little PTSD hearing the governor. I sat on all of those calls during all of the pandemic meetings on a regular basis, to see him and so many others again in that space and that coalition. I guess I would really emphasize three major things. I think I could talk down all sorts of different avenues, but that I wanted to highlight really at the beginning. And this is something actually Ashish Jha had said earlier about listening. And listening loudly, as someone had once said to me, communication isn't just about speaking, but it's about listening. And I think we've talked about that some, about what happens in local communities, how much really needs to happen. I really agree with what Gordon was talking about earlier, about that federalism of really, I spent a lot of time myself saying, is this gonna work or is this not going to work? But Alaska is as big as Texas, California, and Montana combined. If you were to take Alaska and you were to spread us out over the lower 48, we go from California to Florida to Missouri. We're huge. But we could either look at our geography as our disadvantage and think about the fact that it took 2 to 3 weeks at times to get one test from a local community to a testing center, or we could look at our geography as our advantage and look at how we could test people when they came into community and identify cases early, how we could really lean into point of care testing so that local communities could have the tools and resources they needed to identify cases early and say, what does that community need? And so if it was in Utqiagvik, they wanted to talk about COVID with the whaling captains on ham radio, which was very different than Juneau, who wanted to talk about the city council with the municipality there. And so I think just like federalism has its strengths and weaknesses, Alaska's geography has its strengths and weaknesses. But if we can lean into the strengths of federalism, if we can lean into the successes of that rather than focusing on the negative, I think that we can build off of that space much more quickly. And I think a big part of that is listening loudly to our communities and building in the infrastructure early so that they can be a part of the conversation and discussion. I think the second big thing is just figuring out how do we actually build together a healthcare and public health system. We've heard a lot about public health, and then we've heard about crisis, and we've heard about, what do we do when there is, a natural disaster. And I was actually thinking of the Admiral up here as a trauma surgeon. I'm an ER physician, and when you're an ER physician, you learn, the surgeon stands here, and the anesthesiologist stands here, and this is the nurse's role. And you don't just practice it when the traumas come in, you practice it all the time. And I oftentimes say, I'm less worried about the next pandemic, and I'm more worried about my next shift. I think that we need to be thinking about the structure and infrastructure of healthcare and how do we braid in public health and healthcare from a policy perspective and a practice perspective. We were just talking before we came up here. I've wondered how many of my patients I see in the emergency department never chose to get vaccinated because they've gone bankrupt from medical debt. How much of that mistrust in the healthcare system led to their mistrust in the way that they were actually able to practice? So how do we braid healthcare and public health together? We have EMTALA, which is one large piece, but how do we do that? And the third last thing I would say is just how do we unlock the innovation of private sector and local communities to do amazing things? And I think we've heard about that, but how do we, when we do that, not forget about who are we leaving out in that place? Not every community has a Walgreens. We might all have a Starbucks, or a lot of them do, but not everyone's based with Starbucks. So how do we make sure that we're able to think not just within our local community and our state, but who isn't at that table, and how do we listen loudly across those spaces?
Thank you, Anne. And I'm going to come back to that theme of how do we take some of these innovations that we've been hearing about all day and that we've learned about from all of you and make them permanent or be able to replicate them on a larger basis. So I'm glad you raised that. I'd like to turn next to you. Mr. Cody Kinsley, Secretary Kinsley, is the Secretary of Health and Human Services in the state of North Carolina. He's also the former Chief Deputy Secretary for Health and Operations, lead for the COVID-19 response in North Carolina. Cody was appointed to his cabinet position by Governor Roy Cooper, unanimously confirmed, and he oversees a very large budget of $38 billion, has also served in management roles and senior levels in the Department of Treasury, so comes to this experience with COVID with a lot of operational expertise as well. Cody, I'd love to hear from you, your experience when you were serving in that role in North Carolina, and also maybe diving in a little bit on Anne's point about healthcare and the fact that the health system in North Carolina was set up. Will you tell us how it was set up and how it either helped you or didn't?
Sure. Well, it's great to be here, and thank you so much. And it's wonderful to be back with friends. And I have found, you mentioned PTSD, I found this very healing. And so everybody's stories, the calm background music, this is good. It's some sort of EMDR almost. So thank you. When I think about kind of the operational efforts around COVID, I really kind of boil it down to three things: stuff, people, money. And we asked the same questions over and over again about stuff, people, and money, whether, we started with PPE, and then we started with testing, and then we did vaccinations, and then we did therapeutics, and obviously those things lined up, and then we thought about hospital bed capacity and the information thereof over and over and over again. And, it struck me that as we were going through, there's obviously different applications and questions, and I think that's where federalism is really strong, right? Anne's challenges in Alaska, different than my challenges in North Carolina, different than other states, but there are obviously extensible things that we could learn from each other as we apply. But sometimes when it came to the questions about, well, how do we procure PPE? How do we distribute and stand up mass testing sites? How do we do vaccination sites and therapeutic sites? We're kind of reinventing the wheel for the different thing, as opposed to thinking about those things being the same, and we're really standing up retail infrastructure that we want to be extensible to be available for testing today, vaccines tomorrow, therapeutics the next day, and structuring contract vehicles and relationships with private sector partners to do any one of those things and not make them bespoke solutions each time. And so I started, leaning into the questions around, well, how do we operationalize this from the stuff, people, financing framework, right? So, and making it so that the stuff can constantly change. I think there's some lessons there as we think about, how CDC operates today, how we do other things. I think that there are a lot of focus on disease. It was someone mentioned earlier how we have I think it was you, sir, how we have an opportunity with HPAI, and we're all of a sudden, we've got a group of people who are avian influenza experts having conversations, and I think we really have to lean into the operational aspects of it. How do we think about this more about what do we learn around contact tracing, the same things that we did before? How do we distribute testing and case investigation, et cetera? And how do we take more of an ops view? And I think that's really helpful. People, it was mentioned already that, I remember over and over again, we'd have questions about, well, how could we create more capacity? Or how could we buy this facility? Or how could we have a stand-up nursing home? And then it would always come back to we don't have any people. There's no people to staff these things. Nobody has some slack there. And so why are we even trying to go after that? We have to think differently. And I think that people one is a big question. And then the last thing I'll hit on, which was my question for the last panel, which is why Ann and I were just talking about it, is, the healthcare financing in this country is just crazy. And I can't say enough, whether it was data or deploying infrastructure or trying to get someone to get a therapeutic, the stumbling blocks that we went through over and over and over again, trying to figure out how to communicate with people and take their financing for their healthcare into the minds of how to do that was so hard. And I think that problem is one that we've got to tackle, both for, the next pandemic, but frankly for now, to be ready for the next pandemic.
Thank you, Cody. And I definitely want to come back to how we're going to do that, and also how all of you are master storytellers, but you're also all policy wonks at heart. I've learned this about you, Cody. I know it about Ann.
Oh, did I use a lot of acronyms?
Dave.
I'm sorry.
No. I meant just the ability, no, not at all. Actually, you're all masterful at making things plain. It's more that you know the nuts and bolts of how things actually work and how to fix them. And I think one of the challenges that we have is we talk in generalities about how we're going to make a perfect system for data or moving stuff, and we actually don't dive deeply enough and figure out how to do it. So I want to get into that on this panel. You are master storytellers, and before I introduce Dave, I also want to drive people who are watching to the website, which is American Democracy and Health Security, all one word, .org. And the stories from all of these people that you're listening to and 33 total Lamplighters are there with information about what they learned in their innovations. So I want to make sure people know that and are looking for that. Dave, this was also cathartic for me, and it's cathartic for me to be, even if not in person with you, on this panel with you as we went through the Ebola response together in the White House. And then a couple of years later, I watched you be put in charge of this, and that was my big sigh of relief in 2020, to be honest with you, and I told you that and I meant it. Dave Bebo is the former head of response and recovery and also acting associate administrator for response and recovery at the U.S. Federal Emergency Management Agency, FEMA, which is in charge of stuff for the United States federal government, but doesn't always do stuff for health emergencies. They were put in charge, I think, for one of the first times ever for a major health crisis during COVID. Dave also has enormous experience at the state and local level and was the Assistant Homeland Security Director for the city of Boston, where he's worked on a number of crises, including work post 9/11. Dave, I'd love to hear your perspective from the federal level about what was happening in the states in 2020 and 2021 with an eye towards some of those operational challenges that you were dealing with, and maybe also a little bit of how FEMA was looking at what it had been through coming out of Hurricane Katrina and watching what CDC was going through, and what you could maybe tell us about how we can get better going forward. Over to you.
Yeah. Thanks, Beth. And it's really an honor to be on this panel with Cody and with Ann and you, and wish I could be there in person. Yeah, I mean, a lot of reflections based on the comments that I've been listening to. As I think about my time at FEMA, having joined the agency in 2009, still very much coming out of the post-Katrina era for the agency and the period of change and renewal that was taking hold in the agency at that time, I reflect on the investment of resources, of time, of focus on building systems that scaled. And those systems that scaled addressed what Cody just so very eloquently noted: people, stuff, and money. And FEMA learned a lot of difficult lessons in the 2000s about the way it needed to build itself for for what was ahead for the agency, with an era of increasing hazard risk, more and more disasters requiring support from the federal government to help out the states and local communities with the effects of disasters. And despite the fact that none of those systems really were designed to scale for a nationwide incident, the most positive pieces of FEMA's support in COVID and FEMA's leadership in COVID that I reflect on are those systems that were able to scale and change the outcome for the country in a positive way during COVID. Specifically, let's talk about people. FEMA has a system that it uses, and when I say system, I generally mean people, process, and technology that helps to identify qualified staff, put them against a need, and get them out the door, track them, and be able to recover them safely after a deployment. Usually FEMA's in the position of grabbing resources from around the country and bringing them into a specific or defined geography. It might be one state, it might be 6 states. As Dr. Benjamin, I think, noted in his question in the last panel, it might be 11 states, right, with a storm that cuts up the East Coast. But by and large, you're grabbing resources from another part of the country and surging them into an area of need. So we saw that system scale and the ability to actually bring that nationwide, especially, I would say, in the vaccination mission, when thousands of federal personnel were being pushed out the door to support that mission, largely simultaneously across the country. And so that's one example. Another example, I would say, and Beth, this comes to your point about kind of making sense of what is actually going on. The fundamental in the response world is you need to be able to gain and maintain situational awareness, that is, understand what's happening. You need to be able to establish some sort of footprint or ability to flow resources, and then you need to be able to deliver those resources and deliver aid to where it's needed. When FEMA was asked to lead operations in March of 2020, we really couldn't see ourselves in the response in terms of what was going on. We knew that things were bad in different parts of the country to different degrees, but we didn't have a sense from the states about what they needed. And that was job one, was to gain and maintain situational awareness, not about the dynamics of disease spread. Others had that in hand, but understanding what were the needs. And here again, another system that scaled was FEMA's ability to serve as a federal front door to ingest requirements from governors and from secretaries of health, from state emergency managers, to be able to see all of those requests and then start to get a sense of what actually needs to be procured and deployed out to areas of need. That was another system that scaled that made a difference and helped us to very early on in our leadership see that we were managing shortages rather than managing resources, which was a paradigm shift for the agency. And the last one that I'll highlight is around funding. FEMA has very extensive authority to deliver dollars to public entities, states and local governments primarily, to address unmet needs. And that system, but for changes that have been made to it for other reasons in 2015, would not have been able to scale to a nationwide incident to move money as quickly as it was able to, $1 billion in the first 6 days of the vaccination mission, as an example, if it had not been designed in the way that it had been. And so the takeaway for me is there are these systems, and this isn't just about the federal government, there are these systems that exist at state level, local level, that are used for other purposes daily. And how do you draw those into the planning so that those are known, and design principles as they're being updated and revised are considering the types of contingencies that we all really need to be considering, both in the pandemic context and the broader disaster and emergency context. I think that is a key reflection for me, is building systems at scale and finding those that can and making sure they're part of the solution going forward.
Thanks, Dave. We're going to dive in a little bit into how the federal government can help with that, and also how states are adapting to that system that you described so well. I'd like to ask a little bit, maybe just really plainly, how should the federal government support the states? All three of you talked about it in just now, and also in the interviews that we did with you leading up to this launch. And Cody, I'd actually like to start with you. You did some work, I know, with the STAT network, which was supported by Rockefeller and helped band states together around buying tests. You also said in one of the videos today that the federal government needs to be a better shipping clerk, and John picked that up in his in what he said, or Steve did, I can't remember who, earlier on. What should the federal government, and I think Gordon actually said in one of his videos, the federal government should get out of the way and cut the red tape. So just being fair across all these perspectives, what should the federal government do? And from your perspective, what did they do well and where can we improve?
So I think that much like thinking about the incident command structure at the state or local level, so much of this just comes down to having clear swim lanes and understanding who's accountable for what. And I think there's a variety, right? But I think what you can't afford, if you have a system in which we've acknowledged that there's not a lot of slack, then what we can't afford is to have any duplication. And so when I think back to kind of how we were divvying up responsibilities among the federal, state, and local level, and I can't emphasize that enough, right? As much as I'm going to say, here's what I think the federal government can do, Raynard Washington, who's the county public health director, is watching from afar, hello, Raynard, would say, well, Cody needed to do this. And so, it all floods that way. But I think that obviously the money, FEMA's ability to backstop at 100% or 75% reimbursement on things, and that is helpful, obviously, for buying stuff, but it's also, frankly, just helpful as a de-risking aspect here, right? I think so much of what you want in a pandemic response or any emergency response is the ability to de-risk the situation. Right, that's why we saw legislatures across the country remove risk from nursing homes and patient transfers and indemnify things, because we just need people to act and then bring lawyers into it. No offense, lawyers. And so that was really important. The money helps in that way too, right? That look, trust us. You're going to get paid. There's a lot of things that qualify under public assistance, and so we'll be able to get that done. And so I think that backstop of the de-risking piece is really key for the federal government and foundational to so much of what they did. The second thing I would say is I think the shipping clerk example is a really important one. So there's just I hope we can all agree that in no way would it make sense for the 50 nifty United States and territories should be competing with each other to buy stuff in an emergency, right? And so a national strategy around sourcing and then divvying up those sources is key. That is where I think we saw it work beautifully in Operation Warp Speed. Where the federal government sourced these in discrete. Look, I didn't love that I only got 3% in a week, but it makes sense based off being 3% of the population, and we can divvy it up. And I think that as opposed to using the team's plane to fly to another country to buy stuff, or the federal government snagging stuff that we bought, or reprioritizing the procurement. I mean, that was time wasted, and I think that's a really key thing. The last example that I'll give, and I'll bring the Centers for Disease Control in here, which is we think about key policies and communications, right? There is obviously, we've all talked about the variety at which these things are applied, and you have to make sure that they are appropriate for your community, your situation, and urban application of stay at home is probably going to look different than Alaska. And but there's something at that level around communications materials and various other things that we shouldn't be duplicating, right? North Carolina leaned in and came up with the 3 Ws and all these other things, and I think that's where other federal leadership could happen and not have to replicate that. We talked a lot about data, I won't double down there, but I agree that sort of national insight is key too. Yeah, I'll stop.
Thank you. And I do want to come back to data. I was waiting, but we'll come back. Anne, I want to turn to you, and a couple of things that you said in the interviews that are online really stuck with us, and I think some of them are reflected actually in the recommendations, which are on behalf of our organizations, not the people we interviewed, but they were obviously informed greatly by what you said, by what you graciously told us. And one of those was around how the federal government and states could work better together on a coordination channel, a mechanism, a network, a way in which there was better ways for discussion about supplies. We also talked about the supply coordination position, part of which is being implemented by the new Office for Pandemic Preparedness and Response. Really permanentizing that supply coordinator role is important. I wonder if you could share a little bit, how did it work in Alaska? I mean, Alaska had such a complex environment. You have such a large population of Alaskan natives and the tribes. You've got people living in dispersed environments. It's just, when you look at Alaska and you look at the logistics challenges, I don't know how you did it, but kudos to you for doing it. What did you learn that you could apply? It feels like you dealt with every challenge you possibly could have, and other states could learn from you.
Yeah, and the supply challenges, I mean, I think we all were faced with it in many ways, but I don't know if you guys have ever ordered anything and there's that little asterisk that says except Hawaii and Alaska. Like, that's real, and that actually is a thing, and no one wants to ship to us. So, when we're a part of Region 10, so Washington, Oregon, and Idaho, and Washington, Oregon, and California kind of joined forces. And they're like, oh, we're gonna buy PPE, and STAT was coming together on the East Coast. And we were like, hey, us too, can we come with you all? And everyone's like, nah, you're too expensive to ship to, good luck. I mean, basically, we couldn't be a part of any organization because we didn't have enough buying power to make it meaningful to them. We were not an economic aid, and that shipping component was a really big deal. So I think we have to really think about, in this kind of federalism conversation, in consolidation, who are we leaving out? As the state who's oftentimes not even on the map, we're oftentimes like, wait, we're still a part of the country. That happens regularly. In fact, there actually is now legislation that's been passed that HHS secretary has to talk to the non-contiguous states as well as the territories during a public health emergency. That has been passed in Congress now because it was such an issue to be able to say, no, wait, we're still a part of the United States. We need to be a part of those conversations. So I think that, that's kind of Alaska territory, Hawaii kind of specific thing, but I think we see this in rural America on a daily basis all the time. I don't think that's unique to Alaska and Hawaii, where we see areas of our country that are left out, or populations because of language, because of race and ethnicity, because of rurality, that are not included in the conversation. And I think we have to find ways to be able to build that in. I think a couple things that I would emphasize that we leaned into. One, Alaska was kind of like, okay, we're on our own, let's just figure it out. That was definitely our attitude in some ways. So what could we do? What was our private sector? Let's make our own testing. Let's have it go up our nurses' noses, and then let's send it to the FDA and see if they'll approve it. And they approved it, and then we suddenly had a testing that was approved. We very much leaned into we had no commercial lab testing in our state. Bus drivers and police officers were dropping off random swabs in urine samples, off to our lab and saying, run this with no labeling. We had to build an entire, essentially, commercial lab structure to be able to support our testing infrastructure. Despite that, we ended up being the most tested state per capita in the nation for that first year. And because we knew that if we did not have visibility into this virus, we were going to have no way to respond. We knew that we have half the nursing home beds than in any other state in the country. We knew that we have one major trauma center. We just knew we did not have the healthcare capacity to be able to respond if people got sick. And so we needed to identify cases super early. I think a couple different things. One, that we can do better in that federal is that communication. I really have to give General Perna huge credit to that. He, in the rollout, both created a structure for data for us to all see that Cody's getting 3% and what's that looking like and what's that not looking like. And so when governors were angry and state health officials were angry, we could go to the data and we could see it, but we also knew what to expect and to be able to come out. But he also met with every region on a regular basis and said, what am I missing? And so when he met with Region 10, he said, what am I missing? And we asked him how the tribal vaccine was going to be administered and how we can count it. And honestly, for Alaska, it was about a 36% calculation error. It was not a small error that had a big impact for us. And this was a week prior to vaccine rollout. And to his credit, he said, let's meet with our team tonight. And basically ended up recalculating the entire nation COVID vaccine schedule a week prior to rollout because of a data point that he missed that honestly really only impacted Alaska and 2 other states, but would have had a tremendous impact on us. And he was willing and open and created that structure to be able to listen. So I think that that's another thing. And the last thing I would say is about communication, not just listening to local and states and what's happening, but I was trying to think as we were talking today, if I could think of an example, maybe you all can think of an example of where regularly with the federal government, they brought a governor with them or the ASTO president with them on stage and said, we're in this together. That's what we did as the states, right? We said, who's our local territory? Who's our tribal leader? Who's our municipal leader? I never saw the federal government say, I'm going to bring our state leaders with us and to talk about the federalism of the way this happens. So all of the federal communication came down as we're in charge, we've got this figured out, rather than saying we are a country of a lot of states and territories. This is what the federal government can do, but here's what the states are doing, here's what the cities are doing, here's what the tribes are doing to be able to respond together. And so I think we need to think about our communication in that way as well.
Thanks, Anne. We are going to open up for Q&A. I want to give Dave a short comment on this issue, given that he sat in the federal role and might have some views about how we can do it better now that you're outside of government. No pressure, Dave. But if folks could be thinking about questions that they have while he's answering, that would be awesome. Dave.
Yeah, one reflection that comes to mind based on this conversation is that and I love the warp speed example. It as a sort of corollary for the broader supply mission, I think we should anticipate that we'll need different things in the next pandemic. Maybe there will be some stuff, to use Cody's parlance. Maybe there'll be some stuff that's the same, and that stuff, right, is likely the focus of the efforts around industrial base and supply chain management and building domestic manufacturing capability. And we should anticipate that there will be some novel requirements. In a market-based economy that we have that brings with it so many benefits, this is one of the challenges, is that pivoting it to equate itself to allocations, and this is going to go here, this is going to go there, is not something that, without a lot more work and pre-planning and agreements, voluntary agreements under the Defense Production Act, for instance, that's gonna work and sort of snap to quickly. And so I think there are a lot of questions remaining about how much better that will go for those novel requirements that emerge next time. And the last thing that I would just say is, you know that I started my career in Boston. This comes back to one of your earlier questions around kind of important roles for the federal government to play. I was an emergency medical technician and then built post 9/11 capabilities with a pretty dramatic investment from the federal government into emergency services and emergency response. And a question that I think is asked rightly is how do we follow that model, which sustains until today, for the same sort of public health requirements that have day-to-day application and become incredibly important for saving and sustaining life in a situation like we had with COVID.
Thanks, Dave. And I think this also harkens back to the point that Dr. Gold made on the previous panel about practicing at a really local level on really specific types of supplies that we might need for really specific threats. H5N1 is top of mind for me right now. We'd love to take a few questions. It would be great if you have them. We'll just go ahead and collect a couple, and then we'll field them off to the panel. Gordon, I see your hands. Are there others too? All right, we'll start with Gordon.
Yeah, great panel. Love a lot of your comments. This is mostly for Ann and Cody, but can you talk about the importance of just telling what you know and what you don't know, sort of communicating to the public, which is really hard. It's hard to be able to say, we don't know, or this is our best guess. Doesn't sound satisfying to say, but it turns out to be really important. I asked a question. I was struck by John Barry's seminal history of the 1918 pandemic. He ends it by sort of emphasizing that it's so important for credibility to be able to say what you know and what you don't know, and that allows people to sort of wrap their head around risk and to start making their own decisions. Just talk a little bit about how you did that and how you look at that question.
Yeah, I'm happy to dive in. I love that question. I mean, so as a practicing emergency physician, I tell my patients, and I'm sitting side by side with them, that they know their history and they know experience, and I can just bring the science and medicine that I know, but it may not be the right thing for them, and they've got to make that decision. And so I really took my role as the chief medical officer in a very similar way. I'm not the epidemiologist, I'm not the governor, I am not the federal government, I am there to kind of sit side by side. Like many states, we had daily press conferences, and like Utah, we are a very independent state, and people are going to do things their own way. And the governor very much leaned into we are going to do 100% education. We are not going to do mandates. We're not going to tell people how to live their life. And so we just leaned super, super heavily into education. But education was a lot of I don't knows. Like, I don't know what the efficacy of this vaccine is. I don't know how long it's going to last. And I found that being able to empower local community level leaders with the information so that they could then message it and then follow up the questions was even more important than me saying, I'm not sure or I don't know. So if we had a new case of COVID, if we had the seafood processing plant have a huge outbreak, we would say, who's the tribal leader, who's the municipal leader, who's the elected leader, and have them speak to the situation. We would brief them beforehand. We would say, what do you need? What support do you need? What resources? We would be on with them to say, and we're here to support them. But then they would say, we don't know how long this is going to last, but we're here. Just down the road is the clinic. Or I'm the mayor, and I'm going to be here, and you guys all have my telephone number. You can give me a call. And we would say, and they have our phone, so we can be able to be there. So I think it's I don't know, and we'll figure it out together. I think we have to not lose that optimism and hope as we say, I don't know. And I think that putting those two together was key.
Yeah, I love this question, and I think, foundational to this, and we've touched on it many times, is this, how do you maintain the public's trust? And how do you build and grow that trust? And I know that has been, that was our leading goal when Mandy Cohen, my predecessor, was in her role, and it's still her goal at the CDC, and trying to rethink how do we recalibrate and re-grab that trust. And I would add a few other kind of elements to this. One is, what we know, what we don't know, also what we're going to do, and then doing it, right? I think the kind of steady drumbeat of we're going to do this, and then delivering on it over time to kind of rebuild that, I think is really key. And that can be really hard in a super dynamic situation. Two other, I love Ann's point about the trusted messengers and how do you leverage that? How do you bring more people along? And I love the example about how do federal and states kind of appear together. Two other examples. One, there were different communication channels. Right, so we've all referenced the press conferences that were happening, and obviously there's lightning focus on that, and people were looking at it all the time. We also did these I did daily calls with our providers in the behavioral health space, and we did these weekly calls with our hospitals. There's so many other channels where these things happen, and frankly, some of the time it was just and now I will put you on speaker for you to scream. And because people just had to have a space to let it all out. There was so much anxiety, but and I think this is really hard when everybody's looking at you trying to, get the answer for you to say, we do not know the answer to that, but I'm writing it down. We're going to look into it. I'm going to come back to you with the best information that we have. I'm going to go back out to all my state friends. We're going to be on the governor coordination calls, and I'm going to give you feedback on what we learn about it, and then actually following up and doing it. And those sorts of just routine, engagements is really key. The other communication channel, back to and I think this is a big question for me, to this press conference space, is that, the media had their own kind of interest space in this. And I don't know, how, and maybe there's been groups that have convened the media to be how did we cover this? Did we cover it appropriately? How did we share the information? And we started, to be frank, we started to think about it as we had different interest groups, and we had the media as their own, in and of themselves, interest group in this. And I think there's something there for us to understand. It wasn't just they were a channel. They were, as in particular positions of power, to take this information and to share it, and to portray their leaders as people being in positions of trust and what that meant, and the kind of broader incentives happening in journalism right now and various other things. It wasn't just a pass through, and I think that's another big question for us as we think about the future.
And I'll just say we're at time. I'm going to do last words, though, and start with you, Dave, as we go in reverse. So be thinking about what you want to get on the table. I do want to say that each and every person, almost to a T, that we interviewed said something about the daily communications, the daily press conferences, but they didn't happen right away. And there were questions. Governor Hutchinson, when he was interviewed by us, said that people actually, he was wondering if he should do them every day, if that was overkill, if it was too much. And so just recording that was a best practice that should just automatically happen, I think is actually a finding worth speaking about here. So I'm glad that you both brought it out. We're going to talk in the next panel a little bit about playbooks at the local level, and we've got some people here that help build those playbooks. Dave, in your opinion, as your last word in maybe a minute, 30 seconds or less, what kind of playbooks do we need for the future? And what would you, if you had a magic wand, what are the things you would fix?
So I think I would build on what seemed to go really well in COVID in terms of collaboration across various government entities that brought different problem-solving skills, different problem-solving capabilities to bear successfully and did things that they weren't necessarily planning to do. I found a lot of the plans, you want to talk about playbooks, I found a lot of the plans to be fairly quaint and not well suited to what we actually experienced. And so that meant a lot of writing the playbook as you were executing it. I think, though, that we have a generation of public health leaders, of healthcare leaders, of emergency managers, of transportation officials and transit officials, and pick your set of government leaders and a set of private sector leaders who had this very life-changing experience, and that we have to draw on that collective experience to document how to do it better next time. Because I'll tell you that going through certain contingencies in my final year or so with FEMA that really required a bit of a Cold War mindset, there weren't a lot of people around that had led through that era. And that was a real challenge for agencies to need to try and draw that experience from other sources. I think we ought to try and learn that lesson here and take advantage of the talent, the ingenuity that we have to document the better way forward. Not just in government, but we're seeing private sector entities perhaps learning a lot faster than government in this way, how to be more resilient against a range of threats to the business. And so I think we've got to follow that lead.
Thanks, Dave. Cody, last words?
So one of the things that, going back to the kind of who does what, one of the roles that North Carolina kind of leaned into that I really loved was, at some point, everybody wanted to get involved, right? Like we were all dealing with people calling, how can I help? What can I do? We want to help out, And, we were leveraging our faith leaders to be trusted messengers. We were, trying to get everybody on the same page. And at some point it became really clear to us that, we just need to be the marketplace to bring these folks together. And so we created a map that showed by zip code vaccination rates, when they were high enough. We showed as much information as we could as far as the kind of case counts and various other things at that level as well. We overlaid it with, here are your faith leaders. We overlaid it with other civic organizations. We overlaid it with your testing centers. And we put phone numbers on there and said, go be friends. And go work together and solve the problems and do it. And we stepped out of the way. Here's the playbooks, here's the information, here's the resources you need. And we just served as the marketplace for that. And I think that as we think about these different roles and responsibilities, that's a fun way for us to try to, how do we bring people together? And that's where federalism and I think this kind of innovation can shine the brightest. The last thing I'll just say, sorry, the two last words, was, any playbook that we write, like healthcare is changing aggressively fast. Like we've had 12 hospitals closed in rural North Carolina in the last decade. We have the first Hill-Burton hospital in the country in North Carolina. Like the amount of reinvestment to maintain, and I don't need a 70-bed hospital in Aurora, North Carolina anymore. Like we have got to rethink, like that slack is shrinking. And how we respond to a global pandemic that behaves in a similar way is not going to look the same with the healthcare infrastructure we're going to have in 5 or 10 years, not to mention the workforce and all these other aspects. And so I think this is a very dynamic situation, and then I'll punchline healthcare financing. Got to fix it.
And last word, I guess I will share with you the greatest gift that I think I was given, and that was from Alaska Native elders who told me the story of the 1918 pandemic and the Great Death. And they shared with us again and again about how finding ways to be resilient brought together a community. There was nothing like standing in the orphanage of the 1918 pandemic in Dillingham, where they said this is where the orphans were kept, that's now the hospital, to say this virus came into our community because of people moving around and because we were told to huddle together. And what we learned is not to huddle together, but when there's something bad, that you go out, you fish, you hunt, you be, and you realize that things move, give it time, and it will be better, but stay connected to community, culture, and purpose. And we really leaned into that heavily. And more than any playbook, really listening to Alaska Native elders talk about their experience in the 1918 pandemic gave me a playbook on how to think about. I went for a run this morning, and I had this quote that Jane Goodall had said that just really resonated: bringing together the clever brain and the human heart with an eye to optimism. And I feel like the more that we can bring together the clever brain and these systems with the human heart and the person at the center with an eye to optimism, we can bring these systems together. And then the last thing I would say is what an elder said to me once. She said, "This is not your knowledge to keep. What are you doing with it?" So I just really want to thank this group with all of the knowledge that is in this room. It's not yours to keep. It belongs to the next generation. So what are you doing with it to share it and to help to process it through so that the next pandemic, the next shift, the next space, we're all able to be able to respond with that lessons learned and that humility.
Thank you, Anne. That is the perfect place to leave this panel. Thank you, Anne, Cody, David.
Well done.
And on the screen coming up is former Nebraska Governor Pete Ricketts, now U.S. Senator Pete Ricketts.
As we think about emergencies in this country, any emergency, they are locally executed, state managed, and federally supported. And that's true for hurricanes, tornadoes, floods, and in the case of this, the pandemic. When we're talking about what we did in Nebraska, I think we should keep that in mind, that states are going to be different. And I think there's lessons on what we did right in Nebraska, but also understanding that a one-size-fits-all answer is not going to be what we're going to be able to come up with here. In Nebraska, we were very fortunate that we had some of the best advice from world-leading experts at the University of Nebraska Medical Center. So Jeff Gold and his team. And we actually sat down with them and got briefed on March 2nd with regard to what we knew at the time about what this coming pandemic was going to be. And one of the best pieces of advice they gave me was, hey, this is a virus. You can't stop it. The best you can do is slow it down and preserve your hospital capacity. Because at the time, again, really nobody knew what was going on. But when he said, the key here is preserve your hospital capacity so that you can take care of the people who are going to be really, really sick. So I think we started off with a very clear goal that says we're going to preserve hospital capacity. That is going to be our North Star. We really set the tone for the state by, hey, this is what our goal is. We communicated that goal. We were transparent about the goal. We showed how we were measuring it. We communicated that out through press conferences. We were at one point doing 7 press conferences a week, 5 in English, 2 in Spanish. Then we also came up with a plan, which again, we communicated very clearly about how this was going to work. The 6 pillars of our plan were, testing, contact tracing, ensuring that we had a proper PPE, making sure we had quarantine space for people who wanted it, coming up with plans for at-risk communities. So think about anybody congregate living. So whether it was going to be people in skilled nursing facilities or in our prisons or in food processing plants, any place where you have people that are going to, by necessity, have to be in close proximity. So we had special plans for that. We also did a lot of communication with different groups. We got on the phone weekly with hospital CEOs to bring them on board. The entire state of Nebraska became one big hospital system. We did a whole campaign of 21 days to stay home, stay healthy, stay connected. We had a clear goal. We were data-driven. We communicated out. We educated people. We were also consistent with regard to that. Part of leadership is everybody's got to be on board, and everybody on your team has got to do exactly what we say we're going to do.
right, great. Hello, everyone. I'm Jennifer Nuzzo. I'm director of the Pandemic Center at the Brown University School of Public Health. Thank you for sticking it out. We're in the home stretch. And I'm with Cody. I'm finding today's session extremely soothing, especially as I'm getting sort of alerts about new avian flu cases, and I'm feeling bolstered by the fact that we're filling our toolbox with what works, which is really great. So this panel right now is called Lifelines, and we named it that because we want to talk about now in this session what we do to connect leaders with communities and communities with leaders. And this is a really important discussion. This is an election year, you might have heard. And you may have also heard the phrase that all politics is local. And I would say that health security, all health security is local. And for me, this became quite clear pretty early in the pandemic. I remember it was March of 2020, I got a text from a mom friend, a local mom friend, who sent me a text saying, oh my gosh, I can't believe they're closing our kids' schools for 2 weeks. What are we gonna do? And as you might remember, it was a bit longer than 2 weeks. But she was reaching out to me not because of any particular expertise, but she was, just reaching out because she was a member of the community and trying to figure out what could we do, what kind of, she needed help and was trying to figure out what to do to get that help. Many Americans needed help during the pandemic. And so in our session, we're gonna talk about efforts taken to help to ensure that Americans get the help they need, and also to solicit their help in navigating these crises. So I'm really excited about this topic, and I want to introduce each of our speakers and then queue up the conversations, hear about their experiences. So first, let me introduce on the screen, we have Vicki Lowe. Vicki is the executive director of the American Indian Health Commission. She is a descendant of the Jamestown S'Klallam tribe and the Bella Coola First Nations, and she began working in the Jamestown tribe's health program in 1996. She joined the American Indian Health Commission in 2012 and became executive director in 2015. And working with AIHC, she has utilized her knowledge of the Indian healthcare delivery system, state and federal regulations that govern the Indian health system, to implement statewide strategies supporting tribal and urban Indian health programs. Welcome, Vicki. Let me also introduce Mr. Tony Gillespie, who is Vice President of Public Policy and Engagement at the Indiana Minority Health Coalition, where he works to drive advocacy activities to promote health equity. Tony has more than 20 years of experience working at the state and community level, addressing the HIV/AIDS and many other chronic disease issues and health disparities. He co-founded Brothers Uplifting Brothers, a grassroots HIV/AIDS organization serving in Northwest Indiana, focused on HIV housing and homelessness programs and primary and secondary prevention services. And then in 1999, Tony joined the Indiana Minority Health Coalition, where he served on numerous federal, state, local, and community advisory boards. Welcome, Tony. Thank you. And last but not least, let me introduce Dr. Dave Stiegel, who is the former Deputy State Superintendent of Innovation and Chief Academic Officer in the Department of Public Instruction for the state of North Carolina. He's currently serving as Chief of System Innovation Branch to the Department of Defense Education Activity. And during the COVID-19 pandemic, North Carolina Governor Roy Cooper named David as co-chair of the statewide COVID-19 Education and Nutrition Response Work Group. And in June of 2020, David co-led the development of the statewide school reopening guidebook and support documents for K-12 public schools, which you called Lighting a Path Forward. And I have to point that out because, as you noticed, we spent a lot of time today talking about lamplighter's and lighting the path forward, and we shamelessly stole that from you with your permission or knowledge. I don't know if you granted permission, but I've been told you knew. You previously served as Vice President for Global Education Management Systems in the Middle East, North Africa, South Asia, as well as serving as the Superintendent for the Newton Conover School. So welcome, David. Okay, so to start us off, I'd like to hear from each of you about your work during the COVID-19 pandemic. And again, we're going to be exploring the theme of sort of connections to communities, and maybe I'll start with you, Tony, if you don't mind. I'd love to hear about your work with Indiana Minority Health Coalition, and particularly how you're able to kind of pivot its focus on the COVID-19 response. Indiana, I've looked at the data, and it, like many other states, and I've spent a lot of time looking at the COVID data as an epidemiologist. In that first year in particular, we saw very clearly how Black and rural communities were hit hardest. And I would just really kind of root your work in sort of that timeline.
Sure. The work of Indiana Minority Health Coalition, we're a statewide entity. We see funding through our state legislature, and we have 22 coalitions around the state that deal with disparity issues, health disparity issues. And through the leadership of, I always say Dr. Reverend Carl Ellison, he's neither, but he certainly speaks with knowledge and experience. We were able to mobilize, put together weekly calls with our coalitions around the state, and initially just served as a way to keep us connected. But it really began to be a place where we exchanged information, did a lot of storytelling to find out what was going on in those communities around the state. And then we brought experts from state government, state leadership, invited them onto those calls. So our coalitions were sharing real-time information, and then they were receiving real-time information in return. And what we were able to do, it was empowering, I think, for all parties involved. And so when other states around the country had issues around contact tracing, in Indiana, it was compounded by the fact we have a large immigrant population, very large Hispanic Latino population, large African population in parts of the state, and language and communication were an issue. And so our coalitions were able to give kind of firsthand breaking news to the state officials. Hey, it's not working sending non-Spanish speaking or non-multi-language speaking contact tracers out to our families. In one household, an Hispanic household, it may be nobody that speaks English other than the children. So you were giving adult health information to children to translate. So those are things, while they may sound small, it was so important, and it was so empowering for our coalitions around the state to be the ones to bring that news. And it was not angry, not yelling, but just more of an exchange of information. And then the state was able to mobilize, the state health department and other state partners were able to mobilize and make that happen. And so in the context of COVID for us, it was an epidemic, but we deal with health disparities, and so many of those health disparities have similar effects. Communication and language is a part of everything that we do. It's been an ongoing battle, as it is nationally, to ensure that when you provide services that are supposed to be relief or assistance or life-saving, it doesn't help if it's not in a language that I understand. And so that just really became germane to the work that we do. And through that work, we did work with the CDC Foundation. We did some incredible storytelling projects where we just listened. These meetings were for an hour every Tuesday, and it just began to be something that everybody looked forward. We were working in place, or working from home, working remotely. And as much as I love my home, I didn't want to be there 24 hours a day, 7 days a week, trying to work. So it really provided some relief and another way for us to address it. And so many of those things that we started then during the pandemic still exist now. We still do our touch-base calls. We still have great relationships at the state level, and we made a lot of new partners coming out of the pandemic. So really, it was a pandemic, but it was really business as usual for us, because engaging populations around the state is our business.
Vicki, maybe I can turn to you to speak about your experience. And when our team interviewed you for this project, you talked about that while we have witnessed over hundreds of years of inequity, tribal governments, their experience during previous health emergencies, you felt that in this instance, there was evidence of having gotten it right. And I'd love to hear more about your, why did you think that?
Yeah, thank you. I squatchy Vikila since Statiplum New Sklayam since New Hawk. My name is Vikila. I'm Jamestown Squalaman, Bella Hula First Nations, and the Executive Director of the American Indian Health Commission. And really, I appreciate the representative from Alaska, talking about the Alaska Native elders, the impacts of the history of the spread of disease and some of the vaccine policies of the federal government, really come forward with us when these kinds of pandemics happen, especially, in H1N1, we felt it really heavy here in Washington State. Tribes have inherent sovereignty, which means they have the right, when it comes to a public health emergency, to make decisions about their community based on what they know they need. They know their communities best, and that especially in the medical countermeasures, so in who the priority populations are for vaccines. And in H1N1, the federal government had chosen a different priority than what the tribes in Washington State had chosen. Many of them, our elders are really important to us. All of our people are at risk. So when the local health jurisdictions in the state found out that the tribes were picking different populations, not understanding their right as sovereign nations to make that choice, they withheld vaccines from tribes. And this is something that's happened in the past with the federal government for some tribes. So, that history comes into play too. And because of that, people died. Vaccines weren't given and people died from H1N1. And our tribal leaders really said, we don't want that to happen ever again. What can we do? And so from 2009 till basically 2020, we worked with the tribes, the local health jurisdictions in the state to address that and make sure that the education happened, but also that systems were in place to really work together. So we had implemented some mutual aid agreements that allowed tribes to ask for help from local health jurisdictions and also help the local health jurisdictions, or tribes could help each other, local health jurisdictions can help each other. So we really worked on that education. So by the time that the vaccines were getting ready to come out for the fall of 2020, we were working with the Secretary of the Department of Health here in Washington State, Secretary Weisman, on adding that tribal sovereignty language to the playbook here. So to the, they called it Annex 9. And he actually met with the staff of the American Indian Health Commission on Zoom, and we sat and we crafted the language together, and he put it in the playbook. And because of that, as I said, this is the first time ever, I think, in the history of the relationship between tribes and the federal and state government that tribal sovereignty was appropriately honored. And the difference that made is that the tribes, the urban Indian health programs here in Washington State, got over 250,000 shots in arms during the first couple years of having vaccines, and they continue to get those shots in arms. And one other thing I wanted to mention, again, thinking about elders, the Native concept of wealth is a little bit different than what I think dominant culture thinks, but it's more that the ability to share something when you have more of it than you need. So taking care of each other and sharing, it was a lesson that I think the tribes really taught the rest of the state during the pandemic.
Thank you. David, you worked specifically on the topic of reopening schools and developed a playbook for it. And we heard a lot of conversation this morning about how closing schools was such a polarizing issue that there was a lot of kind of outpouring of frustration about that. So we're talking about playbooks, but that strikes me as one area where that playbook must have been particularly fraught. So I'd love to hear about how you did that and sort of, who you involved in the process, and then if you have any sort of offer some wisdom for thinking about how to extend the lessons from that process to, other topics or perhaps playbooks for other areas.
Wisdom I'm not sure about, but I can give you our what we've done. And luckily, I was in a state of North Carolina that has zero politics, so that made it work out. In all seriousness, I was in the role of deputy state superintendent. I had been a local school district superintendent for a number of years, and when everything came down, and we all heard in early March, mid-March, I was receiving phone calls on my cell phone from former colleagues that are superintendents, and I had that survivor's remorse of, oh man, what they're dealing with. I can't imagine how they're having to cope with this. And I didn't have the answers. I'm not a health expert. But what we soon realized, we started off with daily calls with the governor's office and with the State Board of Ed chair and with our partners at DHHS. And we just were going through initial guidance. What was the must-dos, the requirements, the state policies, the executive orders. And we knew we could capture these and share these in meaningful ways. So it started out with me just coordinating a daily call with the 115 superintendents and 200 charter school leads. And it started out just them coming on and saying, what do we do? Do we come back in a week? What do we do with students that we heard about athletics. We have state championships happening. Do we cancel those? We have students that are on spring break. Do we bring them back or leave them? Do we stay there? These are school-sponsored trips. Lots of unknowns. And so it became, early on, we realized we need to capture these in a meaningful way. There was no playbook. We had experience with weather-related issues. Hurricane Hugo in the late 80s came through North Carolina. We were closed down for a week or more all across the state. We'd responded to that out of necessity, but there was no playbook. There was no after-action report of what if this happens again? And so we began capturing what are the key issues they're dealing with. Graduation requirements. Students are applying for scholarships, and they need certain requirements to apply for those. And so daily on those calls, I would have the superintendents and the community leaders submit what are the issues. And I would make sure on that call we had experts. If it was the governor's office, the Department of Health and Human Services, if it was our faith-based leaders, whatever it was, we had those experts because we weren't the experts on all the things that needed to be there. And over time, those calls went from daily to weekly, and we knew that not everybody could be on every call, not everybody had the same information. If we don't tell it 10 times, they may misinterpret, a lot of ambiguity. So we wanted to capture it in meaningful ways, so we started recording the calls and then curating what was done in each call. And it started out with just a curation of, on this call, here's the key points. We started with top 10. Here's the top 10 things we discussed. Here's the mandates, the state board policy that you need to follow, the whatever it may be. And then that morphed into, we need to make sure this is easy to navigate. It's not about being beautiful or elaborate. It needs to be ease of use. It needs to be functional, have utility to it. And so we created this playbook, and there was about 40 of us. And we divided up the key functions: staff and student well-being, facilities, child nutrition, financial business services. How do we, all the procurement issues that we had, products coming out, PPEs. There was 1,000 little things. And what most people don't realize is in most communities, the largest employer is the public school system. In most communities, the largest transportation system is the public school system. In most communities, the largest food service system is the school district. So we were the hub of all the questions and concerns that were coming to a lot of communities, especially our rural communities. And so we started curating this playbook. It's a, for lack of better terms, a Google Doc it's close to 200 pages. And every time we would update, everyone that was subscribed to it would get the update. They didn't have to go look to find what's the newest requirement, what legislation has changed. So when they were meeting with their board members, they could lean on us for the answers as much as possible. What that did, it built trust and transparency. We didn't care what your title was, what your experience was. If you had issues, bring them to the table. If you had expertise or wisdom, as you said, step forward and help us understand it. So ours became out of necessity that we didn't have the answers, and we knew, unfortunately, we think experts live 3 states away. We realized our experts were in our own backyard. We just need to bring them to the table to help us solve these problems, and then capture it in a meaningful way so that we don't forget, and we don't make sure that the information shared is not ambiguous.
So maybe kind of off on that last point about making sure we don't forget, I'm struck by, first of all, the level of engagement that you had and the large number of partners that you collectively reached out to and brought forward and established connections that maybe existed but were enhanced or didn't in some cases exist, as Vicki had pointed out. So my next question is about sustainment. It's sort of like, how do we pull this forward to make sure that it doesn't just shut down ahead of the next crisis, that we can, take what we've learned, bring that forward, and make sure that the next situation, we just kind of hit the ground running. And maybe, Vicki, I'll start with you if you have thoughts on that.
Sure, thank you. I mean, we learned so much. We're a statewide organization, so we were already having hybrid meetings, so it was really easy for us to pivot to virtual meetings. And so we had virtual forums for the tribes and the urban programs to come together. We had a virtual forum that we helped host for the governor and the tribal leaders to meet sovereign to really talk about how they were going to keep our Washingtonians safe. And then we had what I would call a giant continuation of operations meeting every week. The agencies came together and shared with the tribes how they were adjusting their programs to the pandemic, you know, what offices were closed, how you could get services online and all that. And so we've cut back on some of that. We're still the tribal meeting that was happening every week, we're still meeting every other week. They don't want to stop meeting because there was too much value in being able to communicate with each other freely during the pandemic. They got updates from the Indian Health Services and the Washington State Department of Health, but mostly they updated each other on what they were working on and shared policies and guidance and even gloves and masks. You know, they shared vaccines. You know, the Pfizer vaccines came in thousands, and so one tribe had the sub-zero freezer, and they would order the pallet of 1,000, and some other tribes could come pick it up from them and use it. So, I mean, that idea of sharing and continuing having those conversations amongst the tribes is important, but we're also continuing those conversations with the state and the state agencies. The Washington State has funded foundational public health services, and they include the tribes as part of the governmental public health system here in Washington State. So the tribes are receiving some public health funding, something they'll get from Indian Health Services, and so we continue to work together. We'll have regional emergency response planning meetings starting in September. We're going to start meeting again and doing that work. So we just keep continuing and getting ready for whatever is going to be next, you know, because there will be something.
Great. Tony, you mentioned that your work is continuing, but I'd love to hear about sort of what are you still doing and how are you sustaining it going forward? I imagine maybe the type of work has shifted, but what are you working on now?
The type of work has shifted, but it was the pandemic provided a space for us to talk about all of it. So not all the calls were COVID. During the pandemic, what unfolded around the country was the fact that limits were placed on Black maternal health is a big focus of Indiana Minority Health Coalition. So limits were placed on who could be in delivery room with mom. We had just launched a doula program specifically targeting Black and Hispanic women in the north central part of the state, and that affected their work greatly. So that's something that we're still working on. That's something that is extremely important. And you mentioned earlier that you looked at Indiana's data, and COVID data, especially in the first year, was dire. But I guess for our organization, at least my perspective, it's always, our health data has always been dire. And I've seen it in legislative meetings. I don't know if it's popular or not, but Indiana, for me, is always at the top of the bad list, at the bottom of the good list. So we really want to see that change. So it's just an ongoing quest. And even though that the pandemic is, people say the pandemic is over, pandemic will never be over. We'll always be having these conversations. We started having conversations about long-term COVID planning and how do you deal with the effects of long-term COVID, some more education around in that area. Vaccines, a huge issue. Indiana was one of the states that really focused on what started as the HPV vaccine, but now it's just vaccines, period, because there's so much misinformation out there, you know, starting with the COVID vaccine, but just spilled over into vaccines, period. So those are still things that we're dealing with. And from, you know, a racial and ethnic target, that now we have to work on diversity and inclusion and either maintaining it or seeing it going away, or how do we pivot? A lot of issues still continue, and I think the strength of Indiana Minority Health Coalition and what we built is just the communication with the local coalitions, with local municipalities, the fact that as a state agency, often other state agencies come to you to serve the rest of the state. We got out of the way. So our coalitions had direct relationships with the State Department of Health and FEMA and some of the other agencies that responded in the pandemic, but it wasn't through us. It was through our local coalition. They could tell the story locally, that if you set up a testing site on that side of town, racial and ethnic minorities are not going to go there. You need to set it up here. Or they were able to provide their church as a place to do it, or pull together some sort of community event where they could bring community out. So that's the strength of what we continue to do. We continue, I think, to engage and build our communities, and it's not second, third, fourth hand information that comes through us, through a lot of state agencies. It's directly to the communities most affected, and I think that's what we're most proud of. We're coming out of this still the same challenges, but we have a much stronger statewide force and presence than we had prior.
And David, I know you've moved on position-wise, and schools are now open, and so the reopening playbook, thankfully, is not quite as necessary at the moment. But I'm, reflecting on and saying that we didn't have the playbook, which I completely understand. Schools around the country were in that same situation exactly. But sort of reflecting back on some of the parallels to earlier crises, the 2009 H1N1 pandemic, which we talked about earlier. Many schools around the country did close, albeit for a much shorter time. And so just kind of carrying that forward, which is how do we, even though we're not actively having to think about it, how do we take what operational lessons you learned and implemented and developed, and the connections and the playbook and even the Google Doc, and make sure that gets carried forward so that the next crisis that hits, who knows who will be in the leadership positions, but to make sure that they have those resources and they know about those resources, and that there's someone else in charge with kind of making sure it gets updated and alerted, et cetera.
Yeah, twofold to that. One, we realized that we had experience with, as a state agency, especially for public education, we were well-versed in creating operational plans, testing plans, and graduation requirements, and curriculum instruction frameworks. And so we realized that this isn't new to us. And so what we've created has been operationalized, and it's not on a shelf. It's still active and online and available. And although it's not specific to COVID-19 necessarily going forward, it wouldn't have to be. It could be replicated. The key components are there. The framework's there, the learning, the points of contact. We know that the key thing we had to do early on is get the right people around the table. In leadership, one of the struggles is making the decision isn't really the hard part. I mean, you have to make a decision, but making the right decision and the most informed decision is what's hard. And to do that, you need to make sure that the stakeholders and those most impacted are around the table or are represented. Make sure that we have it in their language and then they're in the modality that they best can access. So we had a lot of new learnings, and I think those have carried forward. And I will say one of the positives that came of it as we were coming through COVID, through the fall, we realized some amazing things were happening across the state. And I'm sure many states saw this. And so we were blessed to have the opportunity to go out and districts would say, we have this great resource or this great plan, or we've responded well, come see us. And so we started going out and visiting and capturing that and videoing that and curating that. And it's still active today. There's a website. We created a map of North Carolina, and you can look for topics that, we're trying to improve this key thing. Who's doing that well? You can click on it and see it in action. And so we connected districts to one another. And I think one of the great things that's happened, if we have to go through this again, districts realize they don't have to do any of this alone. And it's not just the people that were in charge at that moment. That culture's carried forward. These collaboratives, just like Tony and others have said, are continuing. We have collaboratives that are going on that began with COVID, but will continue to sustain because they lean on each other and they learn from the collective abilities of one another.
I'd like to open up for some questions, and if folks want to kind of get into the queue to ask questions, raise your hand and we'll get the mic. But while we're doing that, I just wanted to reflect, Tony, just maybe to put this question to you specifically, because Indiana is one of the few states, if not the only state, that's done an actual COVID commission. And we have heard throughout this session the prior discussions about, gosh, we really need these sorts of analyses to understand what didn't work. We also need them to understand what did work. I was just wondering if you could tell a little bit for folks who don't know, what you know about the commission and sort of your thoughts on benefits it may have provided.
I think the benefit, the one essential benefit that the commission provided was real-time information that through partners was able to go out across the state and disenfranchised rural communities or whatever community, economically decimated communities around the state were able to get the same real-time information that everybody else got. And that sort of served as a way to, the pandemic was a destroyer for sure, but it provided a sense of, and somebody made the point of the balance. It provided a sense of balance. It wasn't all bad news. It was good news, and it just provided a sort of a confidence that while this is harrowing for the entire state, we have a focus, and our focus is this. We're pivoting, we're moving in this direction. Then we had a public health commission that grew out of the pandemic, and so now, instead of where we were in terms of our state providing public health dollars, it was a windfall of funding that will go on for years to come to, again, strengthen the response. If we strengthen the response of our local communities around the state, we strengthen the response of our state. If our local communities are well and able to move and make decisions and be confident in what they're doing, then that bolsters confidence around the state. We generated a report that has been accessible and used around the state, and it just provided a sense that we'll get through this in a logical way, and we'll be able to move forward. And, the cliche, if Phoenix rises again, it was real. I knew a family that lost 16 family members in less than a year. And how do you navigate through that? Through this commission, focus was given on mental health services and counseling services around the state. And those are the things that are hit or miss around the country in terms of local community and accessibility and insurance and all of the things that play into making those decisions. So I think in Indiana, we have emerged a lot stronger. I know as an organization from a coalition, local and statewide perspective, we're a lot stronger. We've engaged a lot of new partners that you were aware of, but perhaps didn't work with. Our 211 system in the state of Indiana performed tremendously. And again, not just through us as a statewide agency, but strengthening the response and the resolve at the community level, which is primarily our focus.
Let's see if we have a hand up over here.
Yeah, thanks. I just wanted to dig in a little bit more on Tony's point about sort of misinformation and how you combat that in specific communities. And I want to ask specifically about the minority or the vaccine rollout, right? Mm-hmm. And initially that was a real challenge. I think throughout the pandemic it was a challenge. But how did you work to sort of curry relationships with specific community leaders that were trusted, right? And so what I mean the example in Utah is we had a vaccine rollout that was largely, eligibility was based on age, but we aggressively pushed into communities. So for example, working with pastors and with other community leaders in minority populations that were trusted. So they might say, I don't care what the government's telling me to do, but if my pastor's asking me to show up this Saturday morning and get vaccinated, yeah, I might do that. So what kinds of strategies along those lines did you see being effective?
And I may extend that question to all of our panelists, because I'm pretty sure you each have something to say about that, so.
Okay. I think we made the same mistakes as many states did in terms of trying to formulate a statewide response when you really don't. I've never believed that a state entity can effectively serve community. Public health, my whole thing is you cannot provide public health if you don't include the public. And so
good
just
quote
seems
there.
incredibly simple. Creating mechanisms and forums and places to include the public. And I love it that your example was the pastors. Sometimes pastors do great work at the community level, but sometimes they, have misinformation that they promulgate. Like, my work in HIV/AIDS, we had tremendous challenges working with the faith-based community because it was just full of misinformation. And so the best way that we felt to deal with that misinformation was communication, education, and not necessarily coming from us, a statewide agency that may not have a presence at the local community level, but going to those community leaders in our coalitions. Our coalitions are comprised of 22, 23 leaders at local communities. They've been in numerous leadership roles, and they are trusted. And who cares, I'm Tony Gillespie, VP of whatever from wherever, but Sister Eula Mae Johnson has been in the community and trusted and deals with the food bank and deals with schools and PTA. That's our resource, not the mayor, maybe not even the pastor, but that person who is a known spokesperson in that community and trusted and a record of achievement and movement. So just really trusting our local community leaders.
Vicki, I know you specifically worked on that issue too. I'd love to hear from you about that.
Yes, so it's kind of the same. We had tribal leaders who had videos of them getting vaccinated or would show their Band-Aids after the vaccination, really talking to their community members. But I think the message that was really important was from tribal elders and just talking about how important it is for everybody to get vaccinated to help keep your elders safe. We really cherish our elders. And then we have like some urban Indian programs, the Seattle Indian Health Board in Seattle and the Native Project in Spokane. And they really reached out into those communities too and found like the natural leaders, the natural helpers to help with those messages. The Native Project in Spokane not only vaccinated their Native patients, they vaccinated other communities of color, other BIPOCs. And had weekends where they'd say, this weekend we're vaccinating Hispanic people, come down. And it wasn't, a lot of the state vaccine clinics were very military-like, and that's not a place where persons of color really feel safe. And so making sure that we had safe places for people to go and get vaccinated too. A lot of the tribes had giant outdoor vaccine clinics where you could just drive through with your car and get vaccinated. And so pictures of that and letting people know that it's safe. There's a lot of disinformation. It's really frustrating because we spent a lot of years prior to the COVID pandemic really working on 100% vaccination of our tribal communities for, flu vaccines and all the other regular vaccines that we get.
And David, in the context of schools, I'm sure the vaccine issues came up in terms of outreach with teachers.
Once or twice, yeah. Much of what was said here, we worked with our faith-based leaders quite a bit and our nonprofits in our communities, both to help with messaging and we did a lot of our vaccine clinics at schools and faith-based centers and nonprofit centers that were respected, and especially in our rural communities, those were the hubs of the community. And then in our playbook, we actually had a whole section on how to combat misinformation, looking at reliable sources and trying to connect authentic, reliable sources, primary sources of information for people to go on their own if they wanted to investigate, because they were being bombarded with lots of information from lots of sources. And so we tried to educate on primary sources and how to make the decision on your own with the right information from accurate places. So.
Great, thank you. Well, we are at time, but I am very grateful to you all for sharing your insights, for your work, really your work to kind of spur innovations. I think this panel nicely encapsulates sort of one of the fundamental premises that we had in going into this project, which is that the truth of America's pandemic experience was not going to be found if you just read the headlines of news articles that mostly came from some parts of the country representing certain populations, that when you really got into it, it was a much more complex, much more nuanced, and also much more, I think, promising than many of the headlines conveyed. And certainly your work really affirms that hypothesis. So thank you all. Thanks to everyone for your attention today in this session. I hope we take these lessons forward, and so that we're not next time around asking, what should we have done? We have I think, some great examples here of what can be done. So thank you.
Thank you.
Hi, everyone. I just want to say thank you for what was a wonderful session, and thanks for making this rollout so impactful. And thanks for, I know we have a lot of people watching online. Thanks for watching. Thanks for viewing the stories. We're just going to wrap up now with a huge thank you, first and foremost, to the Lamplighter's who shared their stories, and everyone we interviewed who gave us, really, we never in this project heard, we don't want to talk about this. What we heard instead was, please, let's talk about what we got right. We're happy to tell you it didn't work. It's important, but we really want to tell you what we did. That story is not out there, and we really set out to tell that story. And so just to recap the project before closing, we wanted to tell the two stories of this pandemic, one of tragedy that still burdens the present, one of hope that illuminates a path for the future, one that fractured faith in our democracy, and one that showed the strengths of our democracy. And I think you really heard from our panelists ways in which that happened at the ground level. And both of those stories are equally true, and they coexist side by side in our democracy, which is, as we've been reminded again and again, messy, and that's part of what it is. We have no illusions about how difficult it will be to turn the takeaways from this effort, and it was really hard to write them amongst 3 disparate organizations. That was actually part of our journey, was to bring people together who do come at this differently so that we could actually learn from each other, which we did. But it's urgent that we do so. We've heard many references to H5N1. I think people are looking at news today with H5N2. Viruses are out there. Pandemic threats are out there, and they're going to continue to be. We don't know what the next pandemic is going to be, or the next epidemic or health crisis that affects our community, but we do know it's coming, and we do know that we've spent an enormous amount of time, energy, and resources and mental expenditures of everyone in this nation and around the world to try to get us from where we were with the COVID-19 pandemic in 2020 to where we are today. And it would literally be a tragedy if we do not turn that learning into a better response. So if the COVID crisis exposed our worst failings, it also revealed our greatest strengths. And our country now has a chance to define a path forward from despair to hope while memories and learning are fresh. So I just really want to close by the call and a plea to all of you to get involved in this project. We want to hear from you. There's a lot to learn on the website from so many people who are in this room, who we talk to, and who aren't here, and many of whom are listening online. Please learn about their stories. They were extremely generous. There are video snippets, almost 150 to 200 of them online. There are stories and quotes. There's information, and it's all intended to give you a perspective that it really wasn't a lot of commonality across people that you might not expect to see that commonality from. I learned a lot in viewing that information from people that I didn't expect to have the views they did. And it was cathartic, it was healing, and it was important to preserve. And a bit like democracy itself, as Jenny Durkin said in her video, there is no one size fits all. Someone may need a snickerdoodle, someone may need chocolate chip, and we have to figure out how to make those cookies, how to get that recipe right at the state and local level with federal support. So finally, please do read the findings and recommendations. We make some punchy ones and some controversial ones, perhaps, and we want to hear from you. Most importantly, this is an action-oriented group of people. We want to get things done, and so we'd really like to hear from you about how we do that. Steve did the thank yous at the beginning, so I'm not going to read the whole list, but I do just again want to emphasize that this has been a project of the Brown Pandemic Center together with CSIS, who graciously hosted this event today here and did a phenomenal job in doing so. and the COVID Collaborative. And we were assisted in this by the National Academy for State Health Policy, who really did a tremendous amount of work in supporting this effort with support from the CDC Foundation. Thank you to everyone, most importantly to our Lamplighters. We're adjourned. I think there's still some coffee and refreshments out there, and we'd love to get a chance to hear from all of you. Thanks very much. And a special thanks to Steve and his team, Sophia Hirschfeld, Michaela Simoneau, especially for their work today. Thanks all.